Good morning, everybody, and welcome to the North Central London Joint Health Overview and Scrutiny Committee meeting today. I'm just going to tell everybody that there is some filming taking place and recordings have been started, so just so everyone is aware before we start. I'm Councillor Pippa Connor and I'm the chair of the North Central London Joint Health Overview and Scrutiny Committee. As this meeting is taking place online, it's a briefing rather than a formal meeting, but will operate in the same way as our normal meetings. And as I said, please note this meeting may be recorded. In fact, it is being recorded. So I'm going to ask each member to begin by introducing themselves. So I'm going to read out their names, and then if you can then put your camera on and just say hello so that people know who you are. I've got Councillor Tricia Clark.
Yep, hi, I'm Councillor Tricia Clark from Islington. I'm the Vice Chair of this committee.
Excellent, thank you. Councillor Alison Cornelius.
Sorry, just trying to unmute myself. I'm Councillor Alison Cornelius. I chair the Health Scrutiny Committee at Barnet Council. Thank you.
Councillor Lorraine Reaver.
Hi, I'm Lorraine Reaver and I'm the chair of the Health and Adult Social Care in Camden.
Thank you. Councillor Paul Tomlinson.
Hi, good morning. I'm Paul Tomlinson, councillor in St Pancras and Somerstown Ward in Camden and a member of the Health and Adult Social Care Scrutiny Committee.
Excellent, thank you. Councillor Derek Levy.
Morning, everybody. I'm Derek Levy. I chair the Health and Adult Social Care Scrutiny Committee here in Enfield. I represent the ward of Southgate.
Thank you. I've got Councillor, I think we've got Councillor Khalid Moyeed. I think we've got apologies, so I'll come on to those in a moment. We've got Councillor Osh Gantling. I think we might have apologies as well there. Councillor Linda Friedman, I think we've got apologies, and I've got Councillor Tolga Amaz from Enfield.
You won't see Tolga today, I'm pretty sure.
Okay, thank you.
And
so,
Pippa, sorry, Pippa, could I just say, Linda Friedman, Councillor Friedman, did email Fiona Ray and yourself and all of us that she's unavailable this morning, unfortunately.
Yes,
thank
you. I was just about to come on to apologies, so I'm just going
Sorry.
to check with, that's okay. So I'm just going to check with Fiona for apologies for absence.
So Fiona Ray, Clerk to the committee, we've had apologies from Councillor Linda Friedman and Councillor Khaled Moyeed.
Okay, thank you. Any urgent items of urgent business?
No items of urgent business, Chair.
Thank you. Any declarations of interest and conflicts of interest? Okay, I'm going to mention that I'm a member of the RCN and my sister's a GP in Tottenham. I always say that, so I'm just checking the last quick look. Everyone's, so I'm taking it by silence. That means no one has got anything else to declare. Okay, so thank you. So just to let everyone know, the order for the business has been changed. So it's not the same running order as on the agenda that's out in the public domain. Due to the availability of presenters, we've been asked to receive item 7, the update on the Royal Free and the North Middlesex Hospital Partnership. Actually, that is on the agenda item, so that's fine. But that's going to take place prior to the minutes and prior to any deputations that we would normally take first. So we're going to go straight in to the lead officer, Caroline Clark, for the Royal Free. And we've also got Nanina also on the, also due from the North Middlesex Hospital, both CEOs of their respective hospitals, and they're going to come and give us an update on the partnership, the new part, well, an input, or I'm not quite sure how you're going to say this, Caroline, but enhanced partnership, maybe, I think it might be the new term, between the two hospitals. So I'm going to ask if those presenting can sort of, we've got 40 minutes for this item. We obviously want to keep to time, and there'll be quite a lot of questions, I know, from committee members. So I'm going to ask if you can quickly go through Any areas you specifically want to raise with us, any areas that you think we're particularly interested in, particularly around the workforce, community provision, accessibility, finance, any of those sort of key areas, and then I'll take questions from the committee. So going straight on, so that's on pages 11 to 16 in the agenda pack. So I'm going to hand over to Caroline and then Nina. I don't know how you want to take this.
Okay, thank you, Councillor Connor. My name's Caroline Clark. As you said, I'm the Group CEO at the Royal Free, and I'm also the Accountable Officer for the North Middlesex. But North Middlesex has its own Chief Executive, and that's Dr. Nhs Osuji, and we're going to do a double act. So, and Nhs been with us since the middle of last week and can introduce herself and tell you where she comes from. But we're so pleased that she's come to North London, and already she's making lots of changes. So I'll stop flattering you now, Nhs, because it will get embarrassing. But it would be good if you could kind of give colleagues a bit of a brief of where you come from and the type of doctor you are as well, because I think that's highly relevant to our population. What we thought we'd do, and Dominic, I don't know if you've shared the slides, members have them. We've got a couple of slides as a kind of guide, but I thought I'd just do a couple of minutes on why we're working together and what's important to us and the nature of the partnership, and try and address some of those issues that Councillor Connor alluded to just now. And then Nhs, perhaps if you talk a bit more specifically about the benefits and what particularly the residents of this part of London can expect to see in terms of improved services by our partnership. I've spoken to you all a number of times in various different guises. I was the finance director of the Royal Free for a long time, and every time I've come to see you, I've always talked about the nature of partnership and system working, and how important it is that all the providers across North London work together. If one of us is weak, we're all weak. And I suppose that's my starting point. It's really important that we support each other. And that includes primary care, community care, social services, as well as community and acute services. So that's our starting point, to make sure that the residents in Edmonton and Tottenham and Haringey and Enfield get the same level of service as the residents in the south of the patch. And that's what our partnership is all about. So that's our starting point. We've worked together since 2017 in various different ways, and you will have heard various reports from Nhs's predecessor, and you'll have had conversations about kind of our organisational form. I don't want to talk about any of that. This is about how we work together as partners to really improve the quality of services. So this isn't about taking services away from the North Middlesex. So I thought I'd just say that up front. This is about strengthening services up there. It is about giving residents better services and quicker access. So it might be about patients having treatment at Chase Farm rather than North Mid. It might be about some of the more specialist services being consolidated either at UCLH at the Royal Free in the same way that they are at the moment. So if you had a kidney cancer or a liver problem, the chances are wherever you live in North London, you would end up at the Royal Free. If you had the need for neurosurgery, you would end up at UCLH. So that level of consolidation for specialist services already exists, and this isn't any more than just making sure that works. You know about Chase Farm. We rebuilt Chase Farm a couple of years ago, and it's a fantastic facility for all the residents of North London, and we've got to make that work. Post-pandemic, we've realised that more than ever, and we've realised that it's a great facility, not just for Royal Free patients, but for, as I say, everybody. And we want to make it bigger. So actually, you know, at a later date, I hope to be able to talk to you about our plans specifically for Chase Farm, effectively to extend it and make it a bigger surgical hub. So again, that's a promise to put more services in Enfield, not less. I think the other thing, so Councillor Connor talked about community services. So one of the things that we really noticed, and Nhs and I have worked together on this with Sarah Mansorelli and other colleagues from the ICS, is the way that community services are run across North Central London. There's lots of variation, and we want to make sure that we can invest more in the services around the North Middlesex, because we think that that will help it address some of its issues around well, you'll have seen A&E performance, for example, but we think that will really help the hospital. So strengthening community services, strengthening primary care services, and Nena, you might want to say a bit more about both those things, but this is about more investments into out of hospital services as well as into the services that the hospitals provide. And then the other two things I just wanted to say, and then Nena, I'll hand over to you, is it's a real opportunity for our staff to work across the system. So, you know, we already have staff that work between the Royal Free and the North Mid. We'll do more of that, not to take stuff away from the North Mid, but actually to give them more opportunities. And we learn from each other in the partnership, and that's really important because it gives us a chance to improve services. And there's plenty of really brilliant things going on at the North Mid that I've been super impressed by in the last 9 months that I've been working there. And I think, you know, they're things that I want the whole of North London to be using. And then the final thing is around money. So just to be super clear, this is about getting more money into the patch, not less, and about, I'm going to say levelling up, but that's so politically loaded. I don't know that I want to use that phrase, but it's about effectively making sure that the patients and residents in that part of the world receive the same deal as patients in the south of the patch. Nena, I'm going to stop talking and hand over to you.
Thank you, Caroline, and thank you, Councillor Connor, for having us and for welcoming me when I started 6 months ago rather than 6 weeks ago here. It's been a pleasure, and I have to say I am enjoying my time at North Mid and all the things that we will do in partnership for the people that we serve. A little bit about me. My name is Dr. Nhs. I'm a hematologist by trade. I'm still practicing. That's important to me when we think about the population we serve and the issues we address in terms of red cell disorders, sickle cell and other conditions. It does put me in a position to understand more holistically. I did my training as a leader in Croydon, so that is a population that is similar in many ways to the population we serve in Enfield and Haringey, and it was a trust that was integrated acute and community, so that understanding of what the full end-to-end pathway could look like is hugely important and something that we can replicate elements of here, customized of course to where we are. The other element that I brought with me is that we did a lot of place-based integration work in Croydon. Again, that's hugely important because when we think about scale, we do need to work on a horizontal platform with North Central London, whether we do that in couplets with the Royal Free, in various other relationships with other partners, or with the entirety of North Central London. And that allows us to get best value and releases time for us to focus on care. But at the same time, we know that the solutions to local problems will be best served by that vertical integration and working with partners, primary care, community services, mental health in place. So I think that's something that I'm particularly keen to work with you to further develop here. I've enjoyed the last 6 months and I was reflecting on what I wanted to say to you all today about partnership, because as Caroline has explained, the clinical partnership between our two organisations is long in the tooth. It's been alive for, since 2017. And I think there's been some really good work done. What's been different recently? I think that by coming together in a formal partnership arrangement, we've made it easier to move faster around some of the things we want to do. So we have established executive to executive meetings, we've got a partnership board, and we've got a memorandum of shared understanding, really, which allows us to more quickly appoint people jointly should we need to. So those are things that have helpfully brought people together. And that's the infrastructure bit. What that infrastructure has also allowed us a relationship bit. So we have people in the room having much more intimate conversations that are relevant and that start with what are we going to do for people, be they our residents, our patients and our staff. I want to talk about the fact that as partners, Royal Free and North Mid, we serve the vast majority of residents in Enfield and Haringey. So what we do together allows us to make sure we do so with equity and parity. It allows us, and one of the areas we're really focused on is that inequality lens. So starting to look at our data, for example, in different strata to understand how we serve, how we recover, how we improve access, thinking actively and proactively about equality is one of the key benefits. And we're talking about bringing our population health committees together so that we are talking with one voice, with one understanding, and looking at the whole footprint to better understand rather than doing this in silos. That better together is about opportunity as well as tactical approach. So some of the elements around our learning development officer, for example, where we had vacancies that arose at the same time. Why wouldn't we have one person do it for both of us? It means that we can maximize the caliber of the person we have, maximize the development of all our staff, and ensure that we have high quality staff across both our organizations with access to the same level of training. So that's one tangible example of what we have already done through closer partnership working. And then there's something more tactical about it. It's where the sum of our individual efforts will be greater by working together. So around elements like clinical services, interventional radiology, those conversations are happening, and you may not see those benefits yet, but you will, because what we will do is behind the scene, release some of the complications, release some of the number of steps in any one journey, so that at the end of the day, the time to care, the speed of access, and the waiting time for patients would be improved. Those are some of the tangible benefits that we want to maximize as we move forward. I'm really conscious about the sense of place. And if I speak about North Mid specifically, this is a local hospital for local people. It will always be a local hospital for local people. We will always have an emergency department here. We'll always have maternity, acute pediatrics, acute medicine, acute surgery, and ITU. We cannot function for our local residents unless we have those core services. But there are other services where we're less able to deliver or less able to staff. And we want to make sure that we increase access to all services. So by partnering up, we will increase the access to more specialist services in a way we locally may not be able to deliver on our own. It's a really important message because I know that when I joined, there was history to this conversation, and that history suggested the threat of loss. And so I start these conversations really clearly with saying these things will always be here. And what we do from here is build on that in a conscious way to make sure that we maximize access to all services for our residents. I wanted to give some other conscious examples of what the benefits have released. And for me, if you're in a partnership, the time to test it is in a crisis. And of course, we've just gone through Omicron and a really significant challenge to all our services. And if you think about what we've done through that partnership arrangement, it was a phone call and a willingness around how do we open up more beds on the Chase Farm site so that we could look after people out of hospital. Brilliantly done, quickly done, mobilized, and in a way that says this is not just about North Mid. Let's make sure these resources, these assets are also available to patients coming out of Barnet as well. So we opened the Cape Town ward because of our partnership strength and ability in a very rapid time frame. We also looked at Chase Farm and said, well, if we are getting so many inpatients with COVID on our North Mid site, and we had 160 patients at any one time, and because we also had to manage the transmissibility of Omicron, it meant that we had to close down our surgical ward. We were able to then utilize the theatres at Chase Farm again very quickly to make sure we didn't disrupt the services for our patients to any huge extent. And I think for me, that's what partnership looks like. And those are some of the deliverables and the benefits that we want to continue to build on. Similarly, we've had a director of clinical services post come up at the Royal Free. And that post has been taken on by one of our own divisional directors at North Mid. Really important. That means that her expertise, her knowledge, and her experience will help her weave together better solutions for the clinical support services, things like pathology, things like radiology, things like pharmacy. And we can start really thinking about how by coming together, that will be better. What does that mean? It means that if I need to manufacture drugs, for example, I can think about how we do it once for both trust with sufficient volume and scale. What does that mean in terms of our staff? It is an attractive post to come to know that you can work across both the specialism that the Royal Free offers and the pathology that North Mid offers. It is a great opportunity. So I'm looking forward to how this moves forward. And lastly, when we think about things like the Inequalities Fund, we know that the population, particularly around North Mid, requires us, a levelling up is the right term, unfortunately. I keep saying it's raising the bar and narrowing the gap. It's doing both things at the same time. So we secured some North Central London Inequalities Fund money to expand our community mentoring scheme. Having started at North Mid, Royal Free has come on board and other partners within North Central London. Again, this just speaks to the volume, the power, the potency of partnership moving forward. Anyone who talks about North Mid always talks about the ED department, so let me leave you with the last bit on ED. The numbers coming through our ED department remain challenging. So an average 500 to 600 attendances, of which less than 10% will actually require admission. So we know that we're getting people coming where they could be dealt with in other settings. We've had some of our voluntary sector come in and do some analysis work with our patients, and we know that 40% of them won't even pick up the phone to their GPs before they come. They come to the hospital because they know the hospital is their health-seeking behaviour. We have worked with primary care colleagues to get some primary care support at our front door. That's been brilliant. It started in December. We will evaluate it and see how we can sort of induce that secondary education point of thinking. But what we also benefited from in partnership was that we looked at different models of how that could be done across different partner organizations. So when we come to sharing our learning, it will be understanding, well, what is the core offer and what is customized to different settings. And again, that is done in partnership. I will also share with you that just the specification of what we needed to do, instead of us having to do it 3 or 4 times, it was done once, and we all did a refinement of that so that we moved at pace to put this solution in place. So I hope that gives you a little bit of a flavour of where the partnership is, what it's starting to deliver, and what our ambitions and commitments are. Happy to take questions.
Okay, thank you so much, both to Nanina and Caroline. Nanina, in particular, you've got a very passionate you put forward a very passionate pitch, really, for the partnership working relationship. So taking everything that you have said and understanding, and that sounds a really positive message. I am going to start with a question and then open up to my colleagues. So obviously within all this positive working relationship and joining up of services and other increase in service that you were talking about, there obviously in any move towards a partnership, there will be risks. And you will have looked at those in great detail. I have absolutely no doubt about that. But what if you wanted to sort of let us as a JHOSC know, because we're local authority councillors, so obviously we're listening with huge interest to how this partnership will be progressing and what that actually means for our residents. So are there any risks that you and Caroline have identified in this sort of increased working relationship together? So it's just, just to sort of start the conversation. And I don't mean this to be negative, but I think it's just in anything that anyone does, we always now sort of look to see where the risks are, because then that allows us to be aware of that and then how we can look to sort of, address those. So I've got Caroline. So Nanina, I didn't know if you wanted to come in first, but I did address that to you, but I've got Caroline's hand up as well. So I don't know who wants to take that question first.
So I'm sure Caroline and I will say similar things. One, I think honesty is important, and that means that we're quite explicit about where there may be challenges and how we deal with them. That means that we are being quite mature about any risks as we face them. So that's to give the assurance to the committee. Secondly, I think we need to acknowledge that this is not the first pass at partnership, and there is a risk around the memory that exists for this, and how we work with you to make sure the messaging is around benefits and around doing what is best together. So I think that is a risk that we do need to hold and recognise. The third risk in any partnership, of course, is making sure it's a partnership of equals. And when we have the Royal Free as an established tertiary trust and North Mid as a district general, many could see it as a rescuing sort of mission. Those are conversations we're having. We're not shying away from anything. We are having a conversation around guess what? Northmid brings things to the table. Royal Free brings things to the table. They're different things. And we need to make sure that when we celebrate, it is by bringing together. So the Inequalities Fund, for example, is where Northmid has led the way. Looking at the appointment of our Director of Ops, it's a Northmid appointee who's going into that job. There's so much pathology here that is wonderful, that in itself will attract clinical attention. And then the specialism of the Royal Free. So making sure that that partnership of equals continues is another. Caroline, is there anything you wanted to add?
Oh, I mean, only that people have memories. It's exactly the point you made, and we're deliberately, this is a partnership. There's a very deliberate usage of words here, and we want people to hear that. But you know, as you say, Nena, people have memories of where we've been before, and actually we're just going to keep talking to you about it and telling you what we've done and be as open and transparent as we can, because actually this is about a better offer for our patients, isn't it? And I think we all want the same thing, but we will deliberately use different language, and we will deliberately be, you know, probably quite boring at some point, because we'll share more with you, and I have nothing else to add really. I think the risks are exactly as you say.
Okay, so thank you. I'm waiting for colleagues' hands to come up, but in the meantime, I'm going to, so somebody else's hand has come up. Trisha's. So I'm going to have Councillor Clark and then Councillor Tomlinson, and I'll save my questions for later. So over to you, Councillor Clark, and then Councillor Levy.
I can't get my picture to come. Oh, there it is. Yep, I love the passion that Caroline and Nene have about the partnership. I really, it's important to keep these, you know, these hospitals going. I just have I hear Caroline saying about we have to get more money into the patch, and you know, we rebuilt Chase Farm, we've got to make it work, and we invest more in services around Northmid. And also the Director of Clinical Services at the Royal Free is also the Director of Clinical Services at the Northmid. You know, so I hear that thing, and I obviously, you know, the way you're going to get more money is obviously by amalgamating services, and the alarm bell I've got is just about losing positions, you know, losing jobs, you know, so that's just my alarm bell that's going. But I do appreciate, you know, really we're working in a background of scarcity of funding. I think that's the you know, the point. But I just want to hear, you know, I hear the passion, and I can hear, the commitment is there, but I just wonder if the money is coming from, you know, reducing staff really. And I know you're talking about not reducing services, but that's my alarm bell.
So we'll take Start's question first, and then I've got Councillor Tomlinson and Councillor Levy, and I'll take both your questions together. Thank you. So over to either Nina or Caroline.
So if I start, sorry, thank you for that. And actually what we do want to have are exactly these conversations. So if there are any aspects that we need to strengthen, good to know in advance. So firstly, the risk of losing jobs. I think I would describe that as the opportunity to create different jobs. One of the things that we see is that as people reach a sort of ceiling in their careers in one organization and they have nowhere to go to develop, or that there's a gap between where they are and very senior levels of leadership. So I think this is an opportunity for career progression for a number of staff, and also for career diversification, because you get different experiences in different organizations. I also see the opportunity for new jobs. And if I use an example where we look at things like digital and cybersecurity, we have the opportunity to think about how we create a new role across both organizations to strengthen both organizations. The reality of where we are, Councillor Clark, is very much that we all hold a certain level of vacancy, and for me, there's a natural opportunity not to reduce jobs, but to increase jobs. But your question is, if we're talking about getting money into the system, I think Caroline was being quite explicit about not just the savings that can come from efficiency and streamlining, but also actively, if we want to wrap community services around the North Mid Hospital, we need an actual investment. And I think in order to secure that investment, working together and having a collective, louder voice will be more powerful. So just to be quite explicit with that, I hope that's helpful.
Okay, thank you. Just checking, Caroline. So just to pick up on the last point, Nanina, you were saying about the money and getting that investment. So our understanding is the ICS is that there's going to be that sort of, joint pool of money. Are you talking from the ICS, or are you talking from sort of more strategically? So NHSE, NHSI. Just very briefly on that.
So I'm going to, I can answer, but I think Sarah wants to come in, and as this is directly in her portfolio, it might be useful to bring her in specifically.
Thanks, Sarah.
Thanks very much, Lena. And I think it's a really good question, because you will know from the work we've been doing on the community services review, Councillor Connor, that we have really exposed some stark inequities. And actually, we've seen those inequities and how they manifest in terms of hospital performance, delays in accident and emergency, delays with discharges. So we can see the full impact of what community services can add. And so we are actually looking at investing into community services, and in particular in that patch around Haringey and Enfield and those areas, because that is where we've found the most significant gaps. And we're looking at a number of ways to invest that. And some of that will be growth monies, which we will get. Some of that will be we will be expecting some kind of system impact from delivering care in a different way. But we'll also be expecting providers to deliver care differently in a way that actually achieves some productivity gains. And then there are a number of, as you know, fragile services that we just need to think differently about, given the workforce resilience challenges that we have. But we are absolutely talking about new investment into community services, and particularly in that area.
Okay, thank you. I'm going to move on to Councillor Thompson and Councillor Levy. If you both ask your questions, that would be great, and then we'll take answers from either Caroline, Nanina or Sarah, depending on which areas they cover.
Thank you very much for the presentations. I think, Caroline, you mentioned that you want to make Chase Farm bigger. Now, that relates in a way to our further discussions later on in the agenda today. What could you describe briefly what you have in mind and which particular services you're looking to develop? Thank you.
Okay, thank you. And then Councillor Levy, if you could ask your question as well. Thank you.
Okay. Thank you. Thanks for the presentation. My point is adjunctive to some of what we've heard, and it also picks up, I think, on the staff retention, staff recruitment issues as well. And it's against a public health background. I heard the point, Nana, that you talked about not just the clinical integration and the clinical specialisms, but the human resource integration, transportation between the various sites across North London, North Mid to Enfield, to Barnet, to the Royal Free. And there was a point several years ago, there was, which doesn't just relate to staff, of course, but it also relates to patients who've got multiple issues who may have to go from site to site at different times. Now, there was talk a few years ago with a previous a staff member at North Mid of trying to get physical transportation, whether through TfL or through a private sponsor service, to have a circular bus route or something that actually gets people from A to B to C on a permanent basis and get people out of their cars, which is a problem because of low traffic neighbourhoods. So I know this is not quite on the clinical side of things, which points I think were well made, but I think it's very relevant, because if people have to go from site to site and become effective and efficient in their work, and if they are inhibited by transportation, having a bus that carries 40 or 50 people rather than 50 cars actually becomes more efficient. Is there an underlying transportation strategy within the integration and partnership work that you're doing, whether it's delivered by TfL or a private company, is immaterial at this point. Because I think it really is important, because you've got a consultant who has to be in Hampstead one moment and Edmonton the next. You don't really think they're going to sit on the 102 bus, do you?
Thank you for those questions. Okay, I don't know who's, so if you just sort of, Caroline.
Shall I take the Chase Farm question, and then you might want to consider transportation, although just to say I have tried cycling between the two sites, and I've done it about 3 times now, and it's nearly made me keel over each time, but that's a serious intent behind the question. I understand that, and we will come back to that. Just on Chase Farm, so you'll have talked to this committee about the elective orthopaedic centre, which effectively is code for Chase Farm is now the orthopaedic hub for both patients from Barnet and Enfield and some from Haringey. And we're trying to do, as Nena was describing before, more and more kind of relatively low complex surgery through one place, because the more you specialise, the higher the quality and the more patients that you can do, you become more productive. So the plan for Chase Farm, as we come out of COVID and as we get into the kind of new world, is for it to become a surgical hub for North London. And that will require it doing more orthopaedics and more of a number of other surgical specialties to be defined. But they will be specialties where we have lots of patients on the waiting list. So between us and the North Middlesex, we've got about 120,000 patients waiting for some kind of treatment. Mainly about 80% of those patients are waiting for a conversation with a clinician or possibly a diagnostic. But 20% of them are waiting for some kind of treatment. And we remember that we had about 90,000 before COVID, so it's gone up about 25% after COVID, and you'll have heard those numbers nationally. So the national number now is what, 6 million patients are on a waiting list. So this is our local version of that. So we clearly need more surgical capacity in the patch to do that. I take the other councillor's point, Councillor Clark's point, that there isn't any money coming into the system, or not enough money, but we also have a very big and growing problem with patients waiting, and we need to address that. So we are thinking very carefully now across North London about what other surgical capacity we need to address our own waiting list problem, and Chase Farm will be part of that answer. So the straight answer to your question is we've got to make what we've got work as well as possible now, make it more productive, understood, but then we will need some more theatres and some more surgeons and some more anaesthetists and some more nurses to actually address that big waiting list problem, and that's what we're working on at the moment. And I'd welcome the chance to come back and talk to you when those plans are a little bit more substantial.
Thank you. And on transport, a hugely relevant question, actually, and the conversation with TfL is on the list of things to do. That's not just about convenience and productivity of staff. It's not just about convenience and cost for patients. It's also about the green agenda and sustainability, which both our organisations have signed up to. So I don't have an answer, but it is something that we have been thinking about, because that access needs to include transport access for patients. I am conscious that individually, most trusts have reasonable access. That the question comes as to travelling between the trust sites more than anything else. So there are ongoing conversations planned, and I can come back as and when those mature.
Okay, thank you. Those been really interesting, and I think the bit that I've taken from this update is that how much we do need to keep in touch with you, Beth. Because I think it's around, as you said, it's you're progressing at a pace, and it's for us to understand as the local authorities as to how local authorities fit into this and how we understand what changes you're looking to make, especially around community care provision. So one of the recommendations that I'm thinking about, well, there's 2 actually. So one is around the understanding around workforce issues. So this is going to be something that we are taking as a larger agenda item for a future work day, which we're going to be discussing at the end of the meeting today. And I think the conversation around workforce is, I mean, this isn't just you, this is all hospitals. I completely understand that, but actually it'd be really helpful to come back and have that conversation with you around a new initiative to try and help increase numbers in our workforce and retain workforce, and the pressures that our workforces are currently under, and how we can possibly try to mitigate some of that when we do know that the work environments are very stressful for staff. So I think just because of staff shortages, to be honest, it's not the environment necessarily, it's the fact that they just need more colleagues to be in that to alleviate some of the pressures that they're currently under. So I think that would be one recommendation from this panel, that we take a future update from you both around workforce. And the second one would be around understanding how the local authorities and this new community service review fits together. Now, this is probably best done within each of our own areas. So in Haringey, I can say that, because I chair the Adults in Health Scrutiny panel at the moment, that it would be really interesting for you guys to come to us, you know, after May, at some point in the future, but to have that discussion around that community service review and understand how that impacts. I'm sure Enfield in particular, and maybe other colleagues who've got the Royal Free and Chase Farm in their patches will also be interested in taking. So I think you might be a tad busy, but I think it's really helpful for us to have the time to scrutinise our own areas in ways that we can't do to JHOSC, because we're just taking the strategic look. But I think the nuances of how that could make a change and impact on our residents for each of our boroughs, I think, is something that we all, as individual members, I think will probably look to. So I'm afraid you might have some invitations coming your way after May. So I hope you don't mind that. That would be really helpful to work with you around that new community service review. I've got sorry, I saw Councillor Levy also wanted to come in at this point. So I can't see the conversation, I could just see that.
Yeah, I just put something up on the chat actually, because I thought you were running out of time, but it's you, Caroline. I listened to what you said about Chase Farm, and I only live 1,000 metres away from Chase Farm, so I know it very, very well. Obviously, the physical site is transformed radically in recent times. You and I know that there's a massive housing development, a school or schools being built. So if the service expansion beyond merely staff expansion is to become realised, is it possible to accommodate that within the brand new spanking fresh building, and or does it require physical build, wider infrastructure? And if so, is it something that can be done within the confines of the traditional Chase Farm site, or is it something that might need to be done in the vicinity of Chase Farm, but not necessarily on the site? Because the ambition is great. I think local Enfield people would see that as moving closer to the district hospital it once was, in the manner that Nena was saying about North Mid. But is it? I won't repeat. I think the question is clear from what I've said so far.
Yeah, I can answer that very quickly, Councillor Connor, if that's helpful. So when we built Chase Farm, we built it thinking we might have to put more infrastructure on it. So in fact, it's tiered a bit like a wedding cake. I'm not a builder, so I can't explain it in detail, but effectively we'll be able to expand it relatively easily if we can get the money for it. So that's, but I take your point that we couldn't put anything else extra on that site. It would have to go on the existing building, and that's the plan.
So there was already built-in contingency. Okay,
yeah.
Fine. Thank you.
Thank you for that. So from myself, there's two recommendations. One's the JHOSC recommendation around workforce, coming back to the JHOSC, and the second one is around individual, coming back to the HOSCs, around the community service review, and particularly for those who are in close proximity to yourselves, around how that actually will impact us as local authorities, as we also look to do joint partnership working around community services. So I think those are the two that I have. So just quickly to the panel, just to make sure there's a committee, to make sure there's any other recommendations. Okay, thank you. I don't see any. So thank you both, Nanina and Caroline. I know you came in at reasonably short notice. It was much appreciated from us, and it was really interesting to get this update. We will have some more questions, but we will take those in our HOSCs, I think, for you. But thank you for coming to give us that update. Okay, so thank you very much. And we're going to move on to the next agenda item. We've got the NHS Dental Services. That's on page 29, and it was the agenda item, scrolling through, number 9. We've got Kelly, Nisa and Andrew Biggerdike. coming to speak to us today. So I've got Kelly and Andrew on. So thank you. So just very briefly, the reason we asked for a dental review or dental update, I should say, not review, but a dental update, was we had concerns as a panel, in particular around for children about access to NHS dental care. We know pre-pandemic there was already concerns around being able to get hold of an NHS dentist in London and also for adults. And we were really interested to know how the service is currently able to offer out NHS services as we come out slowly, very slowly, I should say, of the COVID-19 pandemic. So we've obviously, again, only got 45 minutes for this item. So if I could ask both of you to speak quite briefly to the paper that you've already given us, and then we'll open it up to for members' questions. So thank you. I don't know who would like to start, whether it's Andrew or Kelly.
Okay, I'll start if that's okay. So my name's Kelly Nhs. I'm the regional lead for dentistry, pharmacy and ophthalmic services for London. Andrew is the dental lead for the acute services and specialist services and children's services. So between us, I speak very fast anyway, so hopefully not too fast. The presentation and going through that won't take us long at all. I'm sure we'll probably be talking a lot more about questions afterwards. We also have Raki Patel, I think, on the call, who is our public health consultant. So we've asked Raki to come here as well. So Raki, if you are on call, please join wherever you like. So I'll start if that's okay. Andrew will probably come in with regards to various parts of the presentation. Would you like me to share the presentation, or would you like me to just talk to it? What's
No, so we won't talk through the slides if that's
fine.
Okay. What we're asking is just any key points for you to
Yeah,
this
of course, yeah. So I'll go very, very quickly into sort of historical that you're probably mostly aware of. The biggest issue that has caused backlog with regards to dentistry is on the 25th of March, dental practices were asked to close due to the aerosol generated procedures and to ensure safety of patients and safety of staff. When that happened, that took around 12 weeks before practices were asked to open back up. So you can imagine on a daily basis with practices and dental patients that go into a dental practice, putting a stop to that altogether has caused a huge backlog. In regards to the patients that were seen in that period, that was patients only who were in pain, so urgent dental care hubs. Those were set up pretty much overnight by NHS England, so we pulled those together quite quickly. We had a number of hospitals who also stood up as urgent dental care hubs, and all those patients were going via 111 and then being triaged and assessed by dentists and dental nurses. A number of dentists were redeployed into the triage service, so there was sufficient capacity because it became 24/7, and that has been, to be honest, up till now it's still going, so it's 24/7 ever since. As you say, it's a slow process, but the number of calls to that service are still very high. On average, it was around 15 to 1700 calls a day, so a lot of patients coming through to that line and talking to somebody about the toothache that they had. They were referred to a service that had, at that point, you may remember how difficult it was to get things like PPE, so there were only certain practices, a lot of delivering, etc., that happened between our practices. Those services have been continuing in those urgent dental care hubs. We had around 45 at that time, so one pretty much per borough. That has reduced down because targets for practices when they came back on, which was on the 8th of June, were initially 45%. So 45% of their normal capacity. Now, this was due to, again, making sure that they were safe to work with aerosol generated procedures, social distancing and everything else. So the capacity they're working to was much, much less. Now, again, that continued for 2 quarters. So the first 2 quarters, it's increased last year to 65%. I'm pleased to say that in the last quarter, which is the quarter we're in at the moment, the targets for practices are 85%, and they're going to be moving from the 1st of April to 100%. Now, I can tell you that there is a lot of noise in the system as far as practices are concerned, because they don't feel that, with variants and everything else going on, it's still not going to be 100%. It's still difficult. There are issues with regards to workforce, because there's people who have decided they don't want to work in practices. You also are aware of the issues with regards to the vaccination. So where staff are not having that, there's a possibility of losing staff there. And as far as practices are concerned, them trying to do their general practice that they were doing previously compared to how they're working now has changed quite a lot. So in regards to the access that we're receiving, there is a huge backlog for all of London. I won't put a number to that, but you know it's very, very large is what I'll say to you, and therefore the backlog of patients and trying to find an NHS dentist in each borough in London. They have a waiting list. The waiting list varies depending on borough to borough. If you ask me for a list of every single practice that's able to see patients right now, I couldn't give it to you because that changes and it keeps changing, as you can imagine. So some practices have a waiting list of 2 weeks. Some practices are telling patients I can't see them for a month or up to 3 months. So there is a real variance practice to practice. This is also dependent on the size of the NHS contract. So somebody might have a very small contract, somebody could have a larger one. You may have heard about the press release a couple of days ago about £50 million being put into dentistry. I'm pleased to say that NHS London, we have been waiting for any money to come in whatsoever so that we can procure it very quickly and go out there and get expressions. We were informed about it literally this week. We have gone out immediately. We've got a deadline of today for people to come back to us. I'm pleased to say around 70 practices so far have come forward and said we would like to take up the offer. The only issue that people should be aware of with regards to this is it's very easy, as you know, in press releases to make it sound like big chunk of money, we're going to resolve the problem. Unfortunately, it's not. It's short term. It's only for 8 weeks. The funding cannot be accrued over. So from a financial perspective, we can't carry the money over, which means we have to spend that money. And only those patients that get seen in that 8-week period are the ones that are going to get treatment. There is also something about how much treatment can be done, because if you look at the guidance that's come with the funding, it's about making sure that we're getting people stable. Now, what stable looks like can vary, and Raki can probably expand on that a little bit more for me. But it's saying that you won't get a full range of every single band and every single treatment in order to be able to meet that. The funding is being given on an enhanced rate to practices. So, you know, the interest is there, definitely there for the whole country, for all commissioners. We've all talked about this. And it's definitely good news. But as far as access is concerned, there is an access issue for all of London. There is no, you know, there's no fluffing around that at all whatsoever. There was an access issue before the pandemic. It wasn't obviously to this point, and this has obviously increased it massively, and in some areas particularly much worse than it has been before. But we are doing all we can, you know, in regards to making sure that we have an urgent dental care hub service. As I talked about, we've extended it for next year again to make sure there is a 24/7. The phone lines are still there. The urgent dental care hubs are still there. We now have 35 instead of 45, but we still have the urgent dental care hubs working, and we've planned for them to continue. They are working from 8 a.m. in the morning until 1 a.m. So a lot of hours being put in by our practices to continue. There's around 600 patients seen a day. So I can also definitely verify that nobody else in the country has such a comprehensive service, which is 24/7 to ensure that we are getting as many people seen. But yes, we would be being honest if we were to say, are these people only those that are in pain? Yes, they are. But the access funds for the next 8 weeks is going to be for the people outside of that as well. So hopefully where they need treatment done, it's not an emergency as such, but it's pretty urgent. And actually we can hopefully get some of those patients seen. We're not, as I said, we're not going to get everybody in, but whatever we can, we will. There needs to be focus on children, and therefore we're doing a lot of work there. So I'm going to let Andrew talk about the children element and then come back to me if that's okay.
Thank you, Kelly, and Councillor Connor, congratulations for pronouncing my surname correctly. It doesn't happen very often. So I'm Andrew Biggerdike. I am the regional lead for secondary, community and specialist dentistry. So within that, mainstream children, of course, are treated on the high street, but as soon as a child is not mainstream, has additional needs or additional treatment needs, they come under my sort of remit. We'll start with the trusts. So in your area, you have Royal Free, and they currently have no paediatric patients waiting over 104 weeks. 104 weeks is far too long for anybody to wait for treatment, but the goal for the NHS at the moment is to get rid of all 104-week waits. We don't have any in Royal Free. There are a few patients waiting between 52 to 89 weeks, but they will work through the system. Sometimes these patients can't access care because they may be ill, so can't come in on the appointment they've been given. Sometimes the patient's just refusing to come in, or it could be because they also need treatment in another dental specialty, which makes things a bit more difficult. For University College London, which of course is your largest hospital, it's one of the big four and one of the teaching hospitals. For paediatrics, they have only one patient waiting over 104 weeks. And again, this will be a patient that has clinical needs which are preventing them from coming in. But the majority of patients are sitting under 52 weeks. Now, I appreciate that 52 weeks is far too long for any patient to wait for care, particularly a child. But the backlog has been very difficult for dentistry because quite often the priority for these patients is not high enough. So these are children that need GA. But while there is a cancer surgery that has to happen under GA, theatre capacity will be given to those specialties rather than dentistry. And I think we can all understand that. However, it doesn't help this group of patients needing dentistry. So what we've done as a region is secure funding with the help of the North and South Thames paediatric networks. We have sourced funding to provide 3 GA-capable procedure rooms. So these aren't theatres, but they are procedure rooms that are suitable for dentistry under GA. And those have been sited in Barts. And the reason they've gone into Barts is because they had the space and also because North East London has the biggest problem when it comes to long waiters for paediatrics. But this is a London-wide facility that can be used for any trust. Barts currently has the largest number of patients waiting, paediatric patients waiting. So we'll clear all of Bart's long waiters first, and then UCLH will start sending their patients in there. The CDS providers will also be accessing care in there as well. This funding's been secured for 1.5 years. Once that funding's gone, it doesn't mean the facility's gone. It will still be a facility that anybody can use if they want to. I just have to find a bit more money to sort of pay for that. So paediatric dentistry in secondary care, it's being worked through, but it has been challenging. In CDS, so they provide, CDS are the gatekeepers for paediatric care. And where it can be done in the community dental setting, that's what CDS stands for, it is. They, of course, have faced the same pressures that high street dentistry has and hospital dentistry has. They are recovering well. Patients are still being prioritised on need and urgency. I don't think they're going to be at 100% capacity for a while, as Kelly said as well. 100% capacity is very, very difficult with the restrictions we have on in terms of social distancing and fallow time after you've delivered aerosol generating procedures. The other problems that these sites have is they have lifts, and the lifts are often quite small, and you can't fit as many patients in the lifts as you used to be able to. The waiting rooms aren't large, so you can't have large numbers of patients congregating, waiting to be treated. It is proving quite difficult, but good progress is being made. There's also a group of children, looked after children, those who are in care, and they are supposed to have a health check on an annual basis over, I want to say 6, but I could have the age wrong, and every 6 months if they're under that age. We had lots of reports from stakeholders in that group of patients that they were finding it difficult to access care. So we've put a pilot in place, and there are dedicated high street practices who will accept the patients who've recently found themselves in the care system and deliver the treatment they need. It hasn't had the uptake we hoped it would, but of course the launch of it unfortunately coincided with Christmas, which is always a quieter time, and the Omicron wave. That pilot will continue. If it works, we will extend it. If it doesn't work, we may adjust it and put something else in place for these children. We're also looking at oral health promotion and what can be done there. Of course, special schools, people are starting to go back into special schools where there's supervised brushing. That needs to continue. Where supervised brushing can be increased, that's something we would like to do. But of course, this all takes money, and funding is not readily available. We're reliant on local authorities to commission from the community dental services what oral health promotion they want. And some local authorities are very good at this and others are not. It does depend on what pressures you have in your area. If you don't have any care homes in your area, you're not going to commission oral health promotion for care homes. But if you do, and you have schools, then you need to do a bit of both. But in some areas, it's poorly allocated, the funding from local authorities. But NHS England, public health is now part of NHS England, and we work together very closely beforehand anyway. But Raki, myself, and our colleagues are working to find out exactly what is being delivered by the CDS providers in accordance with the commissioning from local authorities, and we can then compare all those and see what patches are missing what services. I'm not sure there's anything else I can update on children.
Okay,
Thanks, Andrew. Raki, did you want to come in before I finish off on the roadmap?
Yeah, sorry, Raki, just to keep it sort of reasonably brief, if that's possible. Thank
Yeah,
you.
it was
It's
just
really
to-
hard when there's so much to tell us. Thank you.
It was one of the questions that came back when we sent the email, was around whether there's variation across the North Central London patch. And I just wanted to give you sort of the vague figures. In 2019, we did a survey of 5-year-old children across every borough in London. And for London, we also did an enhanced survey. So your directors of public health were asked to identify which additional wards they'd like us to go into. So I've pulled the numbers down, and the London average is about 27%. So 27% of 5-year-old children in London in 2019 had decay experience. They had something in their mouth that was decaying, a tooth that was decaying. Now, when you look across the North Central patch, Haringey and Enfield sit well above that average. Barnet sits about at the average, and C&I, we didn't get enough returns to really give an appropriate, but they sit around the average. So you're looking at just over 1 in 4 kids, which is sort of the number we're going at. Andrew's always talked about OHP and part of, working upstream and trying to prevent the disease before we end up trying to access these services, which were under pressure, and how much variance we have in delivery of OHP and commissioning of OHP for children in particular. So I won't go into it until there's questions.
Thank you, and thank you all three of you for giving us a brief summation of what's and increased information on what was in the slide. So thank you for that. That's really helpful. I'm going to look to colleagues. Sorry, I was on conversations. I'm to look to colleagues to see any hands going up. Oh, okay. I'm going to go straight to Councillor Clark, and then Councillor Tomlinson.
Thanks very much. Oh, I just. Thanks to Raki for the update on 5-year-old children and decay. That's very concerning, the number of those children. But Andrew was talking about, the care, prevention and oral health for children in care. Can I just have a bit of information about the prevention and in oral health? The prevention of disease and the public health for children generally. I know in Islington we what's going on in our schools, for example. Is that your remit?
Yeah, so ideally for prevention, we'd like to see water fluoridation in London, but that seems unlikely to happen anytime soon. That would be the best thing we could do. For OHP in children, some schools have supervised brushing programs, and our oral health promotion colleagues in CDS, in the Community Dental Service, go into those schools to oversee that, to install it. We also have special schools are included in that as well. I'm not sure, Kelly, what we've got in terms of any primary care oral health promotion. Do we have any in that area? I don't think so. It's not something that's been piloted yet. We don't have the money for it at the moment. No. So it is limited. We would like more oral health promotion, but it costs money, and we're reliant on local authorities to fund that and make it part of their local OHP priorities.
I can see Raki's hand is up. I'm not sure if she's got any information that I don't.
I was just going to say that the offer across North Central varies borough to borough. So we have sort of a universal offer and then a targeted offer. And as the years have moved on, a lot of, simply because of budget, the targeted offer seems, we'll pick our 5 worst wards or we'll pick our 20 worst schools, seems to be the direction of travel. We won't offer to all, we'll offer to some, we'll offer to the worst. Now, and we do either supervised toothbrushing or fluoride varnish, depending on which is the preferred intervention. For 4 of the boroughs, that is run out of the Whittington Community Dental Service. Barnet in particular has a challenge in that it is not run out of a community dental service. It's now gone to a private provider, and they only commission a children's service. And what that looks like currently is not clear, because it's only just been reprocured out. The other OHP has got, it's a block of money, so it's up to the local authority to direct where they'd like that money spent. Now, historically, a lot of that has gone to children's services and OHP in schools. It's not a huge amount of money. And like Andrew said, really, it's really not enough. But that does leave the other side of care homes, severe mental illness, all the other learning disabilities, all those other groups that actually we should be servicing. It's a balance. So different local authorities will have different priorities. So we're not covering everything comprehensively, if we're honest.
Okay, thank you. And that's quite a sort of, I'm just trying to think of the word, but it's slightly shocking actually that that as Councillor Clark's pointed out, there is sort of 1 in 4 I think you said, Raki, that it was 1 in 4 children in our NCL patch potentially have some form of tooth decay, and that actually the funding required to prevent this in the under 5 or the 5-year-olds that you looked at, that we're just obviously not getting through. And it's really difficult when we hear that it seems to be, well, and forgive me if I've got this wrong, but it did sound like, well, it's either goes, you either sort of prioritise children, or you look at other care home, care home for our elderly, people with learning disabilities. It does seem to be a really difficult situation where those sorts of choices are having to be made because of lack of funding. So just to check, have I got that? Is that correct, or have I misunderstood what you've just said?
No, that's correct. And the other thing is that the data does show there's a complete correlation to IMD. So the more deprived communities have more caries. They have more dental decay. And that's widely been reported for years and years and years. So it is our deprived wards where we did that targeting work where we're seeing increased incidence of dental disease.
Okay, thank you. And that's quite sort of difficult to hear. And I think the challenge probably for JHOSC needs to go back to our local authorities, is to sort of understand from our local authorities as to what funding we have within the public health purse in order to sort of try to, as I've understood, it's not a huge amount of money, but actually if we can stop the decay in that younger age group, will eventually, hopefully, it'll have a huge knock-on effect throughout the whole, process as people do get older. But I do understand that that's a very long term look. So I think there's a challenge to us to go back to our local authorities and understand and ask them as a JHOSC for data around how much money that we are individually putting in and able to put in, and if there could be any other form of funding we could highlight. But I've got Councillor Tomlinson on the call to ask this question. Thank you.
Yes, thank you, Chair. Thank you for the information. It's really very, very interesting. There's mention of an oral health needs assessment on page 33. Can you let us know, please, briefly, where we are with that? When was the last assessment carried out, and how will the assessment actually be done, please? Thank you.
I'll start and then Raki can continue. So the needs assessment, we're smiling because it's something I just asked for a couple of weeks ago and said we need a needs assessment for all of London, because one thing worth mentioning, and you've probably seen this on the roadmap, is some practices have given their contract back or terminating their contract. So they've decided they don't want to stay in the NHS. In total, I think we've got around 5 at the moment, which is a large number for London, to be honest. Doesn't happen very often. So that's for the whole of London as a total. But 2 of them, Raki, correct me if I'm wrong, 2 of them are for Barnet. So we obviously concerned there, and therefore we need to start looking at an immediate solution. The first solution interim is going to be looking at local practices to make sure the patients have got somewhere to go. But longer term, we need to look at procuring those out. So we've got a replacement of those services. So the needs assessment is absolutely vital, because it may not be just the 2. We may want to look at putting more money in if we can. So we're pulling all our pots together at the moment to see how much money we can actually procure. And I'll hand over to Raki about what that process is going to look like.
Thanks. Like Kelly said, it's not a small undertaking. We'd like to do it across London. Historically, we've done we've done borough by borough, we've done different footprints. So the plan would be to pull all the data together we have around inequalities, we have under the surveys that we do. So we have a national survey program that happens every year. We have a small amount of local intelligence. Now, to be honest, a lot of this is pre-COVID data, because very little has happened in the last 2 years. And then cross-match that to the access data. Where are our sites? What are the size of the contract values? And where are our gaps? So to identify, therefore, where are the needs for the populations, be it children, be it adults, be it older adults, and then ascertain whether or not our practices that we want to reprocure are in the right places or whether they need to be moved around.
Okay, thank you. So just following on from that question, I think for me it's quite striking around NHS provision and people handing contracts back. I think is obviously very concerning. And I'm going to ask a really obvious question. I know you're waiting for sort of further data and information, into this. But at the moment, from your own perspectives, you know, from all three of you, if I today suddenly said, right, well, I want to go and get an NHS dentist in my local area. Sorry, Councillor Cornelius, I'll come on to you after this question. If I want to get a NHS dentist in my local area, could I walk in and actually sign up? Because I understand there's a long list for waiting if you're already part of a practice and you're within that NHS system. But I've also heard there are people who are trying to access for the first time NHS dentistry care and are unable to sort of get their foot in the door. So just to be clear, is this just for people who are already in the system and around this, or are you also looking at people who are trying to access and unable to access? And then I've got Councillor Cornelius and Councillor Levy. Thank you.
Okay, I'll take that. So basically, in regards to registration, you're probably aware there is no such thing as registration with a practice anymore. Normally, what would be a patient who is with a practice is a patient who's been there in the last 24 months. Due to COVID, that's changed for a lot of people. A lot of people haven't been able to go over 2 years, and therefore, pretty much that means a majority of people have not been or are not so-called registered or their local practice. So I know that a lot of people have gone back to a practice they normally go to, and their practice said, well, I can't take you on because I've got X amount of patients. So there is a mix in how many patients are being seen. If you're halfway through treatment, a lot of people decided they didn't want to go to a dentist through this whole period. And it is patient choice, and they've said, I don't feel safe, I don't want to go in there because of, you know, it might be because they haven't had the vaccine, or they have had the vaccine but they have a low immune system, or older people who are shielded who are still not comfortable. Therefore, the amount of people that you're going to have going into a dentist, or if you said, can I go in and see a dentist today, the answer to that would be, it's not going to be as easy as it would have been pre-pandemic, definitely not. But patients are definitely being seen, both existing and new patients. So definitely we know that both are being seen. If you said I was in pain, I'd say we can definitely get you a service where somebody would see you to make sure you're not in pain and tie you over until you're able to see a dentist, which could be that if you've gone into a practice and walked in and said, I want to go here, it's the one local to home, they'll give you the timescale of what that could look like. So it could be, like I said before, between 2 weeks to 3 months. With the access funds for the next 2 months, you might see a different NHS for dental services at the moment.
Thank you. And I'll take Councillor Cornelius and Councillor Levy. Thank you.
Sorry, I was just trying to unmute again. I was just noticing, sorry, I was Reki Patel. I was actually trying to get on the phone to our chair of the Health and Wellbeing Board, but I've just got the chair of the Children's Committee. You were mentioning about Barnet particularly, and that we'd now gone, I think your words were, with a private service out of the children's. Could you just elaborate? Because I'd like to obviously go there. I think on our health committee coming up, we've got one in February, that we are having dentistry on our agenda. So I'd like to obviously confirm and make sure with the Children's Committee and the chair of the Health and Wellbeing, just to confirm what you've said about Barnet.
So
just so I'm very clear.
What happened historically with Barnet was that the oral health promotion services commissioned were only for children and young people. They didn't commission anything out of that age group. And that had been previously commissioned to CLCH, who were providing that service. Your community service provider, though, was the Whittingtons. So the clinics were the Whittingtons, but the OHP service for CYP only was from CLCH. That procurement happened recently. Our understanding, and we only heard this week, is that it wasn't re-procured to CLCH. It's been procured to, and I don't know if Andrew or Kelly know anything more than what I heard at the forum the other day, was that it's gone to an external private provider. That's all we know beyond that, or that I've known beyond that.
I thought you mentioned through the Children's Committee or the Children's Service.
No, it's the OHP service from the local authority has commissioned that service, but for the CYP, OHP has gone to a separate provider now, which is not a community provider.
I can get some further detail on that and share it with you if you send me your email address.
That would be very nice, because if we've got this coming to our JHOSC, our health overview and scrutiny meeting, I would like obviously to speak to the chairman of the Children's and also our chairman of the Health and Wellbeing Board, just to make sure they're all joined up and we all know what's going on if that's what's being said in the borough, and we all know. Thank you.
Just to flag that it is only, you know, Barnet historically has only commissioned OHP for children. You've never commissioned any, not you personally, but the services have never commissioned anything for care homes and other groups which you have vast numbers for.
Right.
So there is
Okay.
a stretch.
Okay,
Fine.
so it
I
sounds
probably
like
then need to tell you, Pippa, that I probably need to, as care homes have come into this, that I'm a trustee of Eleanor Palmer Trust that has a 33-bed care home, and we had 78 sheltered. So I will now be asking our care home what they do about dentistry, and just asking how obviously the people in the care home at Eleanor Palmer access dentistry. Just to be,
clear,
thank you.
Want that down as a declaration of interest, is that?
Yes, thank you. Yes, I didn't know that was coming up. It's only just come up.
That's fine. It's good to sort of know as we go through it. And thank you, Andrew. I think that's good, because I think that'll be looked in a bit more detail. So that's very helpful. I've got Councillor Levy, if you'd like to.
Thank you, Chair. Actually, I think this is to Kelly. Even before you presented, I wanted to talk about the Access Fund, because I did see the press release, and I have concerns about it. You've ameliorated by explanation some of those concerns, but my concerns do remain that it looks a bit tokenistic and it looks like a bit of a PR from the government to deal. Clearly, by providing the fund, it acknowledges there is a problem, and the problem is intrinsic both to the dentistry service, to funding, and the NHS overall. But that is why I still think it's tokenistic. Yet it forces the dental services to prioritise, almost make a form of Sophie's choice for emergencies. And of course there are emergencies, and there are grades of emergency, and you're going to do that, you're going to deal with that. But emergencies don't disappear when the money runs out, and emergencies don't disappear within 8 weeks, and you're effectively being asked to put a quart into a pint pot and leave some people behind, and on 8 weeks and 1 day there's a new emergency. So I worry, you may have the same worries within the service and maybe limited what you say, but I worry that anything is better than nothing. To be able to deal with some of the most severe acute problems right now that you otherwise weren't to is a good thing. But the point remains, if there is a need for an access fund to deal with some kind of backlog, it's frankly scratching at the surface. And I don't mean this to be a dental pun, and I don't mean the next bit to be a dental pun, but the root of the problem is much deeper than dealing with an emergency and clearing a backlog. And therefore the concerns I had before you spoke don't disappear, although clearly if some people are going to get the treatment within the 8 weeks, it's got to be a good thing. But I won't repeat, but I think you get the thrust of the point I'm making.
Absolutely. I definitely agree with what you've said, and me and Andrew have probably had these conversations numerous times over the last week. The most difficult thing I think with our roles is exactly that. I've been making noise to ask for money since the beginning of the pandemic. Well, since the opening up of practice, saying if we had any more money, if people have extra rooms and they can use those rooms safely, then it'd be really helpful. And the funding has come at probably the worst timing, as you can imagine, where we can't accrue the funding, we can't do very much with it. And as you say, I've seen this everywhere, which is it's a drop in the ocean, and I probably would have to back that up. It is definitely a drop in the ocean. It's not going to resolve all our issues. The only plus side I think I've mentioned is that in London, what we have done is not said that funding comes and that's the end of it. Our urgent dental care hubs, we've agreed, and that was difficult enough, as you can imagine. You're talking probably around £12 million that Andrew and myself have committed, and we've managed to get our finance team to allow us to continue spending that for our urgent dental care hubs, which means we've still got a service outside of your general, whereas in a lot of areas you could have 1 hour of service, so you'll get full patients seen. To get 600 people in London seen from every single borough, we definitely are pushing, and the areas where the heat maps are, which is East London and East, North East, North Central, are our real top key areas, which are the red areas where there's a lot of deprived parts where people do need a dentist. Those are the ones where we've got more services, more access centres. So we're definitely working on that as a need. And yes, I fully agree with what you've just said.
A very quick rejoinder on that, and because it links to the previous question. I think the point is long term, and always prevention is better than cure. So there's great encouragement from the earlier questions with your paediatric and the young people, and that projecting forward. But in the short and the medium long term, that problem doesn't go away. I think that's the context of the question. I mean, of course, things are a matter of funding, but as we all know, specialists or just members of the public, there's almost nothing worse than dental pain, and it could actually be a very small issue that needs to be treated. It could be a 10-minute procedure to actually cure the pain, almost like a sort of a sledgehammer paracetamol, so to speak. So sometimes the treatment is very short in time, and so therefore I go, the short-term funding isn't good enough. Prevention is better than cure, but I actually think there's scope for an equivalence of this access fund that truly recognises and doesn't play out to the gallery. I have to leave the meeting. The chair knows this now, so I'm going to apologise to you and my fellow members, and I have to go. So thank you.
Okay, thank you.
Bye-bye.
Thank you. Andrew, before you come back in on that, I'm going to ask a really sort of obvious question. You said that this new funding that has been sort of allocated, but just for 8 weeks. I think I heard within the presentation that if the 8 weeks finish and you haven't spent the money, that money disappears. So I'm going to just quickly ask, I know you wanted to come back in, but so are you likely to spend that money within 8 weeks?
Yes.
And if not, what percentage of that funding do you think that you're not going to be able to get through? And I would imagine it's because you just haven't got the facilities in order to be able to get that through in the time that you've been allocated. Thank you.
Sure. So to answer that question, I think the easiest way to put it is, outside of this meeting, my diary has been cleared to do nothing but to spend this money, because that is my priority. So to receive any funds for something like this is fantastic, and I'm not going to waste a penny of it. That's all I can assure you. So I'm out there right now emailing practices as we're going through even this meeting, because and we've been doing that, giving all the hours we can to make sure we spend every penny. So in answer to that, if anything, we're speaking to finance about possibly overspending. We're definitely not going to be underspending this money.
Thank you. So thank you, Kelly. Andrew, sorry, you had your hand up.
Yeah, thank you. So we're not just spending the money in primary care, we are spending it in the community dental service and secondary care, hopefully. So the Whittington, your CDS provider, have already confirmed to deliver additional paediatric special care, and I can't remember the other, it may have been care homes, but they've committed to delivering additional sessions for the next 2 months. UCLH is coming back to me to find out if they can spend additional money to tackle these backlogs. And Councillor Levy is absolutely correct that when this finishes, the need for this cash to address the backlog doesn't disappear, but there's a slim possibility that if we can evidence that we can spend this money and we can address backlogs, we can improve patient access, perhaps that is enough evidence to secure more funding going forward. It may be very unlikely, but Kelly and I, we are doing our best to spend it. And if we could evidence the effect it's had on the residents of London, we may be able to ask for more on a more permanent basis.
Okay, thank you, Andrew. And I'm just going to sort of, so Councillor Cornelius, I'm just checking if that's a legacy hand. I think it might be, because she normally comes on screen and waves at me, so I'm assuming that's a legacy hand. Okay, so we've come to the end of the time allocated for this, and I appreciate you're all incredibly busy, so I just want to say a huge thank you to the three of you for coming on. But as far as JHOSC is concerned, I think I would probably hopefully speak for my colleagues in saying that you know, I'm pretty horrified actually about the times that children and adults have to wait for sort of services. I mean, you talked about you know, a 52-week backlog. So I think that was at UCLH. You know, I know that the dentistry at Barts is opening up to try and help clear this, but I think we've got even greater delays that you've mentioned on this call today. So I think as a JHOSC, I think I just wanted to say that we note the report, but we also want to highlight, I think, I don't know how we make this recommendation. I'm going to take advice from officers, but I think we would completely support your attempts to advocate for further funding to try and reduce some of these really long and extensive delays and, you know, improve the access to the NHS dental services. So, you know, I'm sure you're doing everything you possibly can, but I feel quite strongly that this is an area that has been woefully underfunded, and particularly around the areas that you've mentioned today. And then the final bit was about finding out from our local authorities around the public health funding that we all are putting into addressing the decay that you mentioned with the 5-year-olds in particular, and the oral care that you were particularly highlighting. So there's 2 areas, recommendations. I've got Councillor Clark.
Yeah, it was about that point about checking with our local authorities. How will we do that? Will that be done by each of the people on the committee, or what? So
JHOSC, so our officers on the call today, I'm hopefully going to sort of allocate this to them to ask that if they can get in touch with all the we all know who our heads of public health are at the moment because of COVID, and fortunately our public health leaders have come to prominence. So I think if we get hold of the directors of public health across all of the 5 boroughs and ask for the specifics around the money that's going into that oral health prevention, that's been allocated not only to the 5-year-olds actually, but to the other areas that were mentioned by Andrew about the care homes and the other areas, people with learning disabilities, etc. And if we can have those figures back as an answer back to JHOSC as an update. Thank you. I'm just checking, see if there's anything else. Okay, right. So I think that's it from ourselves. Councillor Clark, I'm just checking with you that there's anything else you want to check.
No, that's fine. Thank you very much. Very good.
Okay. So thank you, and thank you to all 3 of you, Kelly, Andrew, and Raki. So, yes, I'm just trying. Your name's right at the very bottom, so I just had to sort of look down. So thank you very much for coming on the call today, and this information has been really helpful, and yeah, pretty chilling sometimes in some of the information that we get, but it's really good to get that information out there and to make sure that we're all really aware of the struggles that are going on within the dental service. So thank you very much for coming on, and good luck with getting that money spent. Okay, so thank you. So let the 3 of you go, but thank you very much. Okay, so I'm now moving on to the next agenda item. So we've got the estates strategy coming to us. But before that, before I take the official report into that, we've also got the deputation going to speak to us. And as you know, we've taken this out of the normal order just because of time constraints from other people on the call today. So I'm going to go to the deputy. So I've got Brenda who's come up. I'm just seeing if there's anyone else who's coming up to speak, Brenda, or is it just yourself? And I'm going to ask Fiona just to be really clear and give us the outlines for the times for the deputation and for questions. Thank you.
Brenda, I think, sorry, you're on mute.
I can't. Ah, right. Can you hear me now?
Yeah. So Fiona, how long does Brenda have to speak, and how long do we have as a committee to ask questions? Thank you.
Apologies. So Brenda, you have 3 minutes to speak, and then we'll have 15 minutes in total, including the 3 minutes for the deputation. So it'll be until 11:45.
Okay. Well, thanks for letting us come. We weren't able to read the current estates paper before writing this, but I think probably not much has changed since 2018 when it was last presented. In 2018, there was comment about the estates policy really being driven by some financial and NHSE imperatives, and it looks as though things are the same. In today's paper, it talks about there is not enough funding, and there will need to be critical decisions made about priorities. And it's the fact that estates is really bailing out some of the shortcomings in NHS funding. I suppose it is a concern to us. The JHOSC in 2018 talked about lack of accountability and democracy, and also the worry about the erosion of the NHS estate or wealth by the transfer of assets from capital to revenue. And that obviously is a concern because disposals are one-off. They're not a long-term solution. You can't repeat it. Once you've sold land or property, you can't sell it again. So there's an issue about you can do that now, but what about in 5 or 10 years' time? Interestingly, in 2018, in terms of democracy and accountability, it's very clear that local authorities are not on the estate's decision-making board. It's quite a tight board. And I suppose we think that probably better decisions would be made if more stakeholders were involved in that. And also, political and community opposition was outlined as one of the key risks to NLP's estates policy. Now, political and community opposition is you as the JHOSC and me as a member and Alan as members of the public. And I suppose we're very keen that we don't get into that, but look at really what alternatives are. That was again mentioned in 2018, but we're not sure enough has been done about that. So we would urge you to look at how decision-making on estates can be widened out to include more stakeholders, to look at alternatives to disposals, to try and push for the value of the NHS estate to be retained within the NHS. Whether it's sold privately for offices, there's nothing wrong with the private sector and there's nothing wrong with offices, but whether the NHS should be bailing itself out by selling to them is something else. And even worthy things, apparently worthier, like affordable and social housing that may be sold to a housing association, that's robbing Peter to pay Paul. So the JHOSC, we would ask you to work to see the extent to which a wiser, greater group might be able to look at alternatives. Now, that may sound like pie in the sky, but I think one-off sales of generations of taxpayer-funded assets is not a good look for the NHS. I suppose we also want you to press for what are the current drivers. Is it NHS England and some funding? Is it just the shortage of overall funding? And also whether disposals are in the public domain or whether some are protected by commercial confidentiality. And just really to push for alternatives. I mean, we've now read NLP's paper, but it does talk quite a lot about, you know, offices, housing and other disposals, but we can't stress enough that means the NHS doesn't have that resource for the future as its needs change, as demand increases and so on. So we would urge you to pursue that. And this is not meant to be a criticism of NLP. We think they're in a pretty difficult position too. But we do wonder if widening the decision making is going to lead to better rather than worse decisions, which is what they alluded to in 2018. Okay, thank you.
So thank you, Brenda. And just to be really clear, so this is now the opportunity for members to ask questions of the deputy. So that's Brenda. And then obviously there's a chance for Nicola Theron to come back. And apologies, Nicola, you'll have to introduce yourself at that point. And then we'll go on to your presentation. I've got Anthony Brown on the call. Are you also speaking at this? Sorry, just to check. Sorry, I just noticed you're coming up onto my screen. I'm just checking.
Yes, thanks, Councillor. I'm here for Simon Goodwin, who's the CFO. I'm one of the directors of finance. I'm supporting Nicola on this paper.
Okay, excellent. I thought you might be, but I thought I'd just check in case we directed a question at you. So, okay, so I'm going to start straight with members. I've got Councillor Clark's hand's gone straight up. So, Councillor Clark, any questions you'd like to pose to Brenda?
Yeah, thanks, Brenda. I really appreciate you bringing this. I just, you know, the obvious thing is the selling off our assets is you know, it's really a short-term move. You know, and what you've mentioned, the lack of funding. You know, we've got a government that isn't prepared to fund the amount that it promised, you know, to get elected. It lied. I was speaking to a constituent yesterday, and she was sort of won over to Brexit by Boris Johnson's promise of this, you know, the side of the bus saying that so much money would go into the NHS every week, and she's, you know, totally despondent about it. But what what alternatives can you suggest? You know, right now that we could. I agree with you that we need a wider decision-making process. But have you got any sort of suggestions about what we do apart from protest? You know, we need a massive protest about the funding.
I suppose we'd wondered whether there was more scope, and this is not to accuse NLP not having had racked their brains, I'm sure they have, but we have wondered if there's more scope for, particularly given that North Central London has quite a big estate. I mean, it's luckier than some other areas in some respects at high value and high land values, whether more could be done in terms of, to put it in lay speak, renting property rather than disposing of it, so that it retained the value of the estate, but rented either to the private sector for offices or rented to the public sector for affordable housing or other things, but that it stayed as a landowner with assets that could be used in the longer term. Now, in a way, that seems quite an obvious thing, but I'm sure there are some difficulties. But that would release money, or certainly generate income, but also retain the value. And I suppose we were wondering whether there was more, particularly if there were more partners at the table, more that could be done to explore those sort of options. We're aware that money's tight. We're aware that services need to be expanded, not contracted. I mean, we're aware of the capped budget that the ICS will have, and the deficits all around the system. But trying to look even more creatively at options that put us in a better position for the longer term, because I don't see this being, I think Councillor Levy was talking about the dental things. I don't see this being as, oh, we've just got one, you know, there's just been a flood in the house, so we will release a bit of value just to repair the roof. It's not like that. This is going to be a long-term problem, and therefore short-term solutions seem particularly bad. They may be the only ones, but I suppose we're not convinced. So it's really the NHS staying as a landlord, if you like, in some way, and looking at other ways to release finance. I'm sure there are other ways, Councillor Clark, but that was one of the things we've been thinking about.
Okay, thank you. I'm just going to check if there's any more questions to Brenda. Any hands coming up? Otherwise, I'm going to ask a quick question of Brenda. And Brenda, you mentioned about the NCL Estates Board and the sort of representation on that board. So, two questions to yourself. What do you mean by that? So, have you got the specifics around sort of patients and local authority, resident engagement in that? And are you asking that they sit actually on the board, or that they have some, you know, access to the discussions and the minutes that the board takes, and therefore can comment at quite a high level on things that are going on? And the second question is, if there was a representative on that board, obviously the Estates Board will have some quite, and I'm just going to guess it because I don't actually know who's on this, but I can imagine some quite high power figures on that board who are very well versed in the finances and the actual sort of legalities of all the. So what would that person be able to do in that position? So say if one person was, you know, admitted to the board and that was a local authority person or a, you know, a patient representative, what sort of power do you think they would have within that position, and do you think that would actually make any difference? Just being really realistic here.
Yeah, okay. So the first question was about, I mean, the Estates Board, I've looked at the organogram that NLP produced in 2018. There are lots of bodies involved with estates, but it's clear that the Estates Board is the main decision-making board. Local authorities do have representation on some other board, but it's not so key. I think our view would be that body needs to be broadened out with probably equal voting rights. I mean, I think the business of, you were talking about what would other representatives do. and talked about the technocratic expertise in the estates board. But estates and finance is not such, philosophical arcane stuff that local authority representatives or representatives from the voluntary sector or community sectors can't grapple with that. And given that what we've got is a kind of wicked issue, an intractable problem, not enough money to fund increasing services, the idea of a technocratic board being the only people around the table just doesn't sound like a very good idea. You actually need to widen the canvas, because this is not going to be solved by technocrats who know, in my own field, if there's just experts around the table, it doesn't deliver. Sometimes you need other people and other perspectives to look at other solutions. So I don't think it should just be one person. I don't think we think that at all, because there's local authorities, there are different community and patient groups, and one might look at what would be a sensible balance. And this is not to oppose decisions, but to come up with alternative decisions that may protect the NHS, which is something NLP are interested in. It's something local authorities are interested in, patients, community groups, voluntary sector providers of different things, both healthcare, social care and housing. So it's about acknowledging that this is a pretty awful and going to be a long-term problem. And that the way we've set it up, the organograms, the way we've got it, with people like me and people like you councillors perceived as an inherent risk to the whole financial imperative, I just don't think it's the best way to look at this.
Okay, thank you, Brenda. And with that, I'm going to conclude the questions for Brenda as the deputation. I'd like to thank you, Brenda, for your time today. I know you and others put a lot of work into thinking about the challenges that you want to put to us as a JHOSC and to services to sort of, and I know that your heart is in trying to improve it, which I can understand that. So thank you again for that. And we've taken those questions and hopefully got a little bit more clarity. But I'm going to now ask Nicola Theron and Anthony Brown to introduce themselves and to respond to the deputation initially, any areas that you specifically wanted to raise, and then take the estate strategy update to JHOSC, which is on page 17. It's actually under agenda item 8, although obviously that's been moved. And we've also got Sarah Mansorelli on the call as well, I think, as part of this agenda pack. But just before you start, Nicola, I'll say that we would normally just ask you to speak briefly to the pack, and then we would take questions because of the time constraints. So we'll ask for a similar from yourself and Anthony today as well, just to pick out key areas that you wanted to highlight, but I'll come on to that later. So Nicola, over to you to respond, if you'd like, to the deputation.
Thank you, Councillor Connor, and thank you, Brenda, for those points, and you've obviously put a lot of work into it. So just by way of introduction, I'm Nicola Theron. I'm the Director of Estates for North Central London. So I have a sort of oversight responsibility around estate. The ownership of the asset will sit with either the trusts or partners. So we do just need to be clear that differentiation between my role and that of Director of Estate at the organisation. But let me just play you back, if I may. Firstly, I think it's worth just noting that, in fact, we came to the JHOSC last with an estates update in March 2020, just before COVID, and we provided an update that followed that session, and there were a number, I think, quite useful reflections on what you've just said that's in that 2020 document. So the first of which is just picking up on governance and decision making. We have put in we've been putting in a number of different structures, trying to make it as efficient as possible. The Estates Board, which is worth saying is not decision making, now has representations from the council. So we've built that continuity in because, as you've said, it's important that we have a shared voice at the Estates Board, which now works in a much more focused way. So that's the first point I'd make around the Estates Board. We've also got now a really good structure of local estates forums, which bring together a whole range of council colleagues and NHS colleagues at the borough level. And I have to say, I go to these and I am just astounded by the level and depth and richness of the conversation and the energy, some of that energy we were hearing from Caroline and Nina. They are great conversations. They are about how do we, as local borough teams, work together in terms of identifying priorities, looking at where shared agendas can be delivered, looking at how we can secure external money and do so much more proactively than we've done in the past. So there's sort of perhaps two elements that I would suggest there, one of which is the Estates Board and the second of which is the Local Estates Forum. And that sort of governance and accountability and local democracy that you talked about, I think is played out in one of those. And, you know, it's a sort of discussion which if JHOSC would like to join one or other of those conversations, you know, I think you'd really benefit from seeing what's happening locally. Just on your final point, or what you make another point, but just on your point around creativity around disposals, it is worth noting, we can't lose sight of the fact that, say, more than 50% of our primary care estate in NCL is not fit for purpose. So that is what is partly driving the need for investment, but it's also driving the need for realising value from that asset. So that sits at the heart of much of the disposal agenda, and that disposal agenda is all about then how do we reinvest it back into the borough or into a system level. And again, you know, that's been a very strong theme running through what we do. And I think the sort of estate strategy, which I may come on to in a minute, Councillor Connor, it sort of reflects that point, which is local care investment sits absolutely at the heart of what we're doing. It's one of our three main programmes, but it is about how do we make sure, particularly primary care, is fit for purpose, has got the digital infrastructure it needs, but also, importantly, the community and mental health and acute sector as well. Just on your point around capital, you're absolutely right. We have too little capital. We have been quite successful in securing non-local capital, non-NCL capital. So from things like diagnostic centres, we've secured about between 10 to 15 million has gone into diagnostic centres, and we're bidding for more. We've been successful in getting ETTF money in. So we have been quite focused on that, and I think some good outputs to be able to report on. We'd always like more. You're absolutely right. We'd always like more. Anthony, is there anything more you'd just like to pick up on the specific finance points?
Take myself on mute. Yes, thanks. Yeah, not really. No, you've stolen most of my thunder there, actually, Nicola. It's quite a comprehensive response. I guess just to point out, as we've already said, and it's in the pack, and we'll come on to some of the detail in the pack itself around the funding constraints. I think in terms of the system response here, it needs to obviously do that prioritisation piece and make sure it's happy with not only the next 3 years, but the 10 years from where we are at present onwards. So there's a huge amount of work in terms of system discovery of estates priorities and making sure that we're in control of how we're profiling that over the next few years. I guess in doing so as well, it's not a surprise that without enough funding to actually meet or match our ambition in terms of estates, we need to be looking at the things that you've already pointed out, Nicola, in terms of additional funding, whether that be from a national pot or using the likes of, sort of Section 106 monies from local authority colleagues and so on. So it's beneficial in terms of the change in governance that we're looking to work with partners and with NHS England in terms of making sure that we're well plugged into the local and national opportunities that present themselves in terms of capital funding. So yeah, I think most of it is picked up in the pack, and we'll come on to it then again.
And I think the only point I'd want to just add to is we had a very good workshop that Zena Etheridge chaired in December, which was absolutely looking at this shared agenda between the council and the NHS, and how, picking up your point around how do we create a leasing model rather than a purchase model, and actually how can we add value to the council-led projects but by creating 25-year income and meeting our affordability challenges. So there's some again, that's kicked off both a toolkit in terms of how we work together differently, but also working with Sarah Manzarelli and others, how do we then embed that in both and create an affordable model that actually we can plan to. So picking up your point around disposal alternatives and planning, I think that's again a good example of how, despite all that's been going on in COVID, we've been able to really make some important strides in terms of working together and linking that into a shared plan. Again, owned by the local estates forums, because that's where the sort of the traction needs to play out.
Okay, thank you. Thank you so much to Brenda, and thank you for the response to Brenda's deputation, Nicola and Anthony. We're now going to go straight on to the actual papers that you presented to the JHOSC. I am just going to note at the beginning, whilst it was incredibly helpful to have this high level briefing and with the bullet points, I had to note that on slide 3 alone, I had 11 substantive questions following that, because to be honest, we don't know what we don't. So those bullet points, whilst, you know, I was like, wow, okay, that's an enormous amount of money, or gosh, that's a huge change. I don't know the information behind that. And I'm just sort of flagging up at this point now, just for future reference. We've only got a short period of time now to scrutinise, and it's very difficult. We don't know which area to particularly hone in on, because the background information behind that isn't unfortunately available. So I'm just sort of flagging up for future reference that whilst this is an incredibly helpful, you know, starting point, I think we may need to actually take estates again in this after May, just because I think there's quite a substantive amount of information behind each of these high level bullets that you have given us, and we just honestly probably can't do it justice today in scrutinising it in the time that we have. So just to be aware that I know councillors have got an enormous number of questions following this. So I'm going to stop talking now, and so that we don't want to lose any precious time that we have. But if you could give us an update, Nicola and Andrew, and then we'll go into questions. But just to be aware that there's a substantive amount behind this that we'll probably need to come back to. So I'll let you give us the highlights, all the bits you want to let us flag up with us today. So thank you.
Thank you. So I think beyond what we've just talked about, if I can just highlight some of the areas that I would like just to sort of give more visibility to. The first, just in terms of the key headlines, is we have put a lot of focus around making sure we better blend the estates and the digital spend. Quite complicated in the NHS, but we've got some emerging examples of what that looks like. And that's an important point that I think plays through in terms of the strategy. The second would be that we have, as the NHS, we've put additional capacity in at the borough level, very much picking up the points that were made to start with, which it's important that we create that consistency, working with partners, but that we tailor into the local need, the local setting, and particularly reflecting the importance of the equality agenda, making sure we've improved access, etc. So that bringing additional capacity in has been a really important step on the road for this last 2 years since we last came to see you. The third would be, and picking up that point that we just talked about, that whole governance, leadership and oversight with the structure that I've just talked about. It means that there's a much greater coordination in terms of both what is playing out within the council forum as well as the NHS and the overlap to be done. I'm going to pick up on the just the successes and the progress we've seen, all of that. Anthony, do you want to pick up on the estates and digital slide?
Yes, so I'll just be brief because obviously there's questions coming after this as well. So from a finance perspective, really, just the headlines are that it is actually useful that NHS England have moved to giving us a 3-year indication of capital allocations. It does allow for some further planning. The sort of the latest in terms of allocations is that everything's still draft at present. We still haven't been passed final allocations, and the allocations into sort of 23-24 are still actually going to be draft for some time, but it does actually give us an indication of what's coming our way in terms of overall funding, and allows us to actually plan then in terms of how we prioritise and model a state's ambition for the future, and then how do we actually then think about, as we've already mentioned, make best use of national or other local capital funding streams. The headlines for the NCL system is that we can expect in the region of a £20 million reduction next year in the capital envelope for ICS, which is obviously quite bad news in terms of the overall funding and ambition. However, we do have a model at present. We've reached out to trust colleagues and primary care colleagues about the ambition and the prioritisation of schemes over the next couple of years, and we're looking where best possible to make sure that we've got a clinically led prioritisation piece of work, and then obviously making best use of the additional funding streams to make that work. So it is an unfortunately pressured position in terms of funding over the next couple of years. We do expect potential further decrease in the estate's capital funding in the year after that. So the challenge of the system really is how do we ensure we keep our ambition on track and identify funding.
Thank you. And so linking into that, you've seen the numbers. I'm sure I will happy to follow that up in more detail. The gap between what we think we've got, what we're funding at the moment, both in primary, community and acute, and what we need. I've also highlighted within the slide some of the examples of what the total, how that breaks down by modality, by service, and what that looks like at a borough level. Now, I would just add that this is very much work in progress. We are being asked to produce an updated estate strategy, probably in the during the course of this year, to make sure it aligns with the establishment of the ICS. And we are doing a significant piece of work at the moment, really trying to make sure that our particularly primary and PCN priorities reflect both local need, as well as we've said earlier on, really optimise how we can work with councils in delivery of that, both from the state's perspective as well as from planning and capital, as Anthony's talked about. So that's where there's a great deal of work. I think the only other thing to add is I provide an update in the 2020 summary, which was disposals. There have been not actually many disposals because of COVID. So we are pretty much where we were when we last talked to you on that wider point. But there are some high-profile disposals. Those are clearly all playing out into the big St Pancras, Moorfield, and other programmes. So that was a sort of whistle-stop tour of what we said. Yeah, as you say, there's a lot of detail sitting behind it, Councillor Connor, so I will happy to take questions.
Okay, so thank you. I'm going to look to the committee if they would like to start off the questioning. As I said, I had 11 substantive questions just on page 20 alone. So I think I'm going to hold fire and let my colleagues start the process on this. So I've got Councillor Tomlinson. First question.
Yes, thank you very much. And there's a lot there to look at, and the comments coming forward, really from the deputation and really from our own thoughts, have a lot to do with local authority input and representation. And my question really is what your hopes are for the local estates forums. This is quite a new idea. I've not heard of it. I don't know if we have one in Camden, or if we have a role in another forum which includes Camden. I've not heard of it at all, and I think our residents and my constituents will be very interested, because St. Pancras Hospital site is in my ward, in fact, in Camden. Can you enlarge a little bit on your hopes and plans for the local estates forums, and how often they might meet, and who is included on the forums?
Great, thank you. And to pick up Camden, and each one is broadly similar. We have the last one took place about 3 weeks ago. We had probably 20 partners around on the Teams call. Those were probably 5 or 6 from the council, so that included Dan Pope, planning committee, therefore Brian from 106, Jeremy from operational estate. So there's quite a range of different organisations and parts of the council there. We had all of the provider leads, and we had a number of GPs, lead GPs and PCNs attend. So it's an hour that happens once a quarter, but we have informal meetings that take place again on the monthly basis, which really are more like working groups. The piece in Camden, and again many similar to this, is we've secured some OPE money, which again is about how do we secure money from outside the system to support some feasibility work, and that OPE money is looking at a whole series of planning requirements, aligning opportunities around the Belsize Park area, plus other things. So it's exploring and almost acting as the board for that money, although there's a more formal OP board that also takes place at a strategic level. But it also, and I think you mentioned St Pancras, it also just charts the progress of where that large project is going to, but more specifically, as far as the local estates forum, what is happening to the Somerstown primary care project, and making sure that that is meeting the needs at the local level. So we had an update on that, and then last time we had an update on the green agenda and how it related to Camden, and how we might be investing again money that we bid for in order to try and ensure that we've achieved our sustainability objectives. So as an example.
Thank you. A quick follow-up, if I may. It doesn't sound like any councillors were invited to this forum. It sounds like an officer forum. Okay, it would be great if councillors could come. But now, how do we actually find out about the results? Are there any minutes of these meetings at all? Is there anything circulated that we can access to know exactly what's happening?
Yeah, this is a conversation I'm sure we can have hereafter. We because of COVID, I suppose we've been trying to gain momentum on these. We've now got that traction. We've got a terms of reference, which I'm sure we'd be happy to circulate, to give you a sense of their brief. And then, as I mentioned earlier, it would seem to me we would welcome the involvement of councillors, whether it be on an ad hoc basis, on a subject that you're perhaps interested in, or more regularly. It's been something we've discussed, but we've wanted to get the traction going before we sort of widen the scope.
Okay, thank you. So I'm feeling like we've already got, I can feel the beginnings of a recommendation coming out from Councillor Tomlinson's question, and I think one of those will be around understanding the as you said, the governance structure of these local estate forums. I think for us, I'm picking up already that understanding about the minutes and how we have access to and note of what's been discussed, who within our sort of elected group can actually access and come along, whether that would be a cabinet member or an equivalent person, just to put forward the concerns from the local community, because it's great that you've obviously got officers there, that's essential, but actually to have an elected representative to speak on behalf of the community, I think is also essential. And yes, we would like to see the terms of reference around those. And then a final bit on that recommendation is how this actually feeds back up to the main NCL estate board. And you mentioned having that broadened out with the to the local authority. So I wasn't quite sure, but I think the recommendation from today would be understanding how that's been broadened out, who on the local authority or any other groups would be invited or are invited into the NCL estate board, and what their voting rights or are within that, and whether there are any minutes of that estate board. But then actually the obviously the relationship between the main board and the local estate forums is also key, I think, to really understanding how that information is fed up and down between those two. So I'm going to go straight to Councillor Clark. Thank you.
Thanks a lot. Yeah, I think this discussion illustrates the importance of the JHOSC, actually. The fact that there is a forum where we are getting a chance to discuss this, and it's highlighting the issues and communicating with each other. And the other thing is how COVID has actually been a bit of a beneficiary here. We've benefited from COVID, and that it's put a halt to the disposals. On page 7 it says we have to eliminate voids, and we have to improve utilization in existing buildings, and that's a core focus. And so what I'd like to just pick up is some of the questions from the deputation, if that's all right, because one of the questions is what are the current measures requirements from the NHSE that force NCL to divest itself of its assets? Because I know there's a bit of a what's the word? There's funding offered, isn't there, if you've managed to actually sell off our assets? Because even we have to really, I really think the focus has to be on the fact that they are public assets. We've always had this focus on the JHOSC anyway, but we need to really keep that in mind. So you've got this improving utilization in existing buildings as a core focus, and I would like to put like a core focus being retaining those assets. But I'd like to know really what is as the deputation asked. What are the current measures requirements from NHSE that force NCL to divest of assets, and what are the current plans for transfers of disposals? There's a whole list of questions there, Chair. I wonder if we could get answers to them, outside the meeting.
Can I just respond? So in 2020 we provided an update for the disposals, and those, as I say, are pretty much remain the same, as I'm sure Antti and I would be happy to do an update on that. Some of the disposals have happened. So, for example, Burgoyne Road, which was on the to be disposed, has been disposed of, and has been reinvested back into technology for BEH to deliver COVID with IT at the heart of it. So it's been a really good example of how a building that was not fit for purpose is now supporting the workforce and really some really good outcomes. So really happy to provide that update. Secondly, on the what is the sort of E&I position on disposals? And it's worth saying, and I just go back to my my point around primary care with 50% of the assets not fit for purpose. We do not want to be in a system that doesn't recognise that we need to be divesting from some assets in order to invest in others. And that sort of sits at the heart of it. And the voids point that you just talked about is we may need to do changes to our existing assets, and we need to be able to recycle value in order to be able to use what we've got harder, better, and to support the integrated and collaborative delivery model, particularly with digital. So it is part of that. It's part of that process of making sure that we are providing the best possible care for the communities that we support, which is about making sure we've got the assets that are fit for purpose, and that sits at the heart of what we do. Anthony, I don't know, is there anything more you'd want to add?
No, not really. I think in terms of what you're saying here, there's a balance between assets that are fit for purpose and then making sure that we've got an affordable estate strategy going forward. And if we've got funding constraints from NHS England, which I think is sort of what the question was getting at, then part of that is how do we recycle our capital receipts to make sure that that funding is going to support shortfalls as well. So it's that balancing out between fit for purpose estate and actually then an affordable model for estate going forward.
Okay, so thank you. So thank you, Nicola and Anthony, for that quick update. And I do appreciate the amount that lies behind that. So we welcome as a JHOSC that you would come back and provide an update on the disposal of assets. I think it is critical for us to understand as a JHOSC which estates are being disposed of and where that estate is being disposed to, and then what that money is actually being used for. Because I think, as the deputation made sort of did point out, there is this concern that, of course, this is the family silver, and whilst we understand the need around the spend to keep estates going, and especially as you said, Anthony, if you don't think that they are currently being used in the way that the NHS intended, but there is that concern, and I think Nicola, you brought it out when you said that Zena chaired a meeting and about the leasing model, and you talked about a toolkit. I think it's really for us to understand, because our sort of the bit where we sort of have that intake of breath is like, well, once we've sold those, it's gone. And IT, with the best will in the world, we understand why it's needed, but IT needs updating, and then we haven't got Gold Going Road to sell again to get the next IT update. So where do we then find the money from? So I think I'm hoping you're seeing where our sort of level of concern is, and I think it's really difficult because as I said at the outset, I think the papers are very good at sort of giving us a really quick snapshot, but then every bullet point we read, there's that moment where we're going, oh, okay, gosh, that's a lot. So I'm going to go back to Councillor Clark, because I think she probably wants to come back on that. Thank you.
Yeah, thanks very much. That's a really good summary. Just want to reiterate the point about the deputation has done a bit of work and they've got these questions. Can we get those answers? You know, for the next time that we talk about estates, that we have the answers to those questions as well. I know some of them have been answered, but you know, those that haven't.
Sure, thank you, Councillor Clark. And yes, we will include the deputy's questions in any sort of questions that we are asking after this meeting. Okay, so we're going to move on to other questions, because I know that there's a multitude. Now, again, we are very short on time, so we've got about another quarter of an hour of questions. So I'm going to look for members, and while they're thinking, I'm going to ask a question. I'm not going to go on slide 3 with the multitude of questions that I had, but one that really stood out for me on page 24, and that is slide 7, primary care funding. I noticed that there was a really clear note about a funding gap of £40 million. I'm assuming the bullet points under it is how you hope that you would close that funding gap. But there's two questions to that. One is, do you think you would be able to close that funding gap with SIL, council co-funding, ICS funding? I'm not sure what PropCo is, if you could just explain that. And new national funding, I'm also not sure what that is. And is this something that you have some certainty around, or is this something that you are looking at the moment to try and see how much you could access out of that in order to close that gap?
Yeah. So just a really good question, because it captures all that we've been endeavouring to do. So PropCo is NHSPS and Community Health Partnerships, which are the two PropCos within the NHS. So that's where we are, that's how we're defining that. And they provide capital in some instances where we are able to build a strong case for change. So, for example, money going to Kentish Town is coming through from CHP, money coming into Edgware is coming from PS. So we are seeking to optimise that as far as possible, by an example. Picking up your point around the 40 million, so we've really chunked the way this 102 million is that it really divides up almost into 3. So a third we have got underway. So all the great work's happening across each borough is valued at about 30 million at the moment. And we've got all those projects that are bubbling along. I'm sure many of you will know which those are. We've then got another third, the 30 or so million, where we believe we know where that money is coming from through Section 106 and SIL money. That's particularly been effective in Barnet, where we've got our PropCo colleagues who are providing us with some confidence that they will fund the next phase of development. Thirdly, we've got a small amount of national capital in order to be able to fund that next third. The 40% that's in red is really where we have used our current resources up. We've used the discussions around 106 and SIL, and therefore that really is the gap. And what we are hopeful of is, and as Anthony mentioned in the first instance, we've got a small amount that's been allocated through the ICS capital allocation, that we can build on that we can build on. Some of you may be aware of the government policy around Cavell centres, which is an integrated community model that we position one of our projects so that it's ready should that money come over the horizon, as an example. So that 40 million is really where our work in progress needs to focus. But that's not saying that we can take the eye off either of the other two, because as we all know, property transactions are complicated, and we need to get them over into delivery. And we certainly need to make sure that with the wider environment around tighter funding, our property companies are going to actually have less money themselves. So we have to build a very strong case for change and make sure that our priorities are their priorities.
Okay, thank you. So the obvious question is if you don't get the money and this doesn't come through in the way that you are hoping it will, what impact will that make? Because this is a substantial amount of money that seems to be not certain. And so are there critical decisions that you're holding back on at the moment in order to see if that funding actually materialises?
So this is a 5-year plan. So partly that 40 million is in that sort of 3 to 5 year time frame. But undoubtedly it has implications, because these are our priority projects. So these are not nice to have. These are projects that are important to fund growth and the equality agenda going forward. And this is where I think working, and Sarah Mansrelli and I have talked about this, is how do we ensure that we have developed a deliverable pipeline, a pipeline that builds the strategic change opportunities that it has to do. That's where estates as an enabler for change has every opportunity to be played out. But how do we make sure that we have secured, every last opportunity in order to make that medium and long-term pipeline work as well as the short-term pipeline?
So am I a bit correct in thinking that some of the estates that will potentially be sold off or disposed, or whatever other way that leaves your portfolio, whether that then saves you money in no longer having to do the upkeep, or actually generates income obviously money into your into that capital? Can that be? Are you saying that this 40 million would be used for other capitalised programmes, like you said, around MRI scanners, IT, and sort of other estates? Or are you saying that some of that 40 million might actually need to be spent on a revenue stream to sort of try to sort of close the gap on those services?
Yes. So what we are saying is that this is the estate ask. As you've seen in the paper, there are other asks for diagnostics and other uses. The point that you're absolutely right. So there is always a capital or a revenue solution, and with the discussions, Thorley Road in Islington, we are going to secure a revenue solution working with the council on a primary care ground floor. we would. The problem with a revenue solution is that we have revenue pressure. So what we are keen to do is to make sure that we can put what capital we can in order to make it revenue affordable, because obviously the more capital the NHS can bring in, the least revenue cost it has. So there's, part of property is getting that blend between the capital and the revenue, and making sure that the space that we are delivering is as efficient as we can make it. So I suppose the message from this is it is a medium to long-term pipeline. There's constant changes, and I think I mentioned we're doing a piece of work at the moment with PCNs, really to make sure that the priorities we have are the right priorities post-COVID. Thirdly, we are very creative around where capital can come from, both locally and nationally. And fourthly, we are always looking at ways that we can replacing capital where it's not available with an affordable revenue solution. And then that can play back with partners, because clearly a long-term revenue stream with council partners is a commercial and attractive proposition. So hopefully that sort of gives you a sort of a framework in some ways of what is guiding the work that we do.
Okay, thank you. So I think I'm going to park the follow-up on the conversation around, or the scrutiny around the looking at the revenue and how the revenue it fits in with the capital programme, because I think that is quite a complex area. I haven't done it before, and had actually a whole JHOSC just on the finances and the revenue implications from the capital work programme. So I think I'm going to again ask that is taken up as part of a future paper on this area, so that we get a very clear understanding. And I do appreciate it's very difficult to do it in such a short space of time. So I think we're going to give this item a much longer allocation of time, and maybe use a double timing on this one, because obviously we want to really understand that implication. I think that's where a lot of concerns come around, as to whether we're selling off estates to mitigate the revenue stresses that are in the system. And again, it's that whole idea of once it's spent, it's gone, and those revenue pressures will still be there. So it's how it has a long-term solution. I'm looking for hands up, and whilst I don't see any at the moment, I'm just going to ask on page 23, you say the trusts are finalising a 10-year capital pipeline, mix of strategic, transformational and BAU. I think you said replacement schemes coming to £3 billion. Could you just briefly sort of let us know what that actually means? What do you mean when you're saying, yeah, yep. What does that entire bullet point actually mean? Thank you.
Anthony, do you want to do that?
Yeah, I was about to say, so this is part of the planning work that we're doing in terms of the 3-year settlement that NHSC are affording us. We're then obliged to obviously put in draft plans as part of our 22-23 operating plan. So it's our budget process, and that's due to go in late March, early April for submission. The 3 billion figure there, I think it's 3.4 billion. In totality is the 10-year figure for what we think all the trusts will want. So only the excluding primary care, that figure, and we're trying to obviously do something by the way of understanding the pipeline for capital requests in future, and then measure that against the amount of overall funding that we might need. So much in the same way that we just talked about, sort of microcosm of that with respect to primary care and how we actually afford primary care. It's the same sort of exercise, but taking in all of the acute mental health and community trusts here. And the sort of initial estimate is just over £3 billion during the 10-year period. We've done the same exercise also for the next 3 years, of course, because that's the one that's waiting for submission shortly, and much of this then obviously the same conclusions will be reached in terms of a clinically led and with all partners having involvement in terms of solutions, and then looking at maximisation of external funding where we've got funding constraints from the ICS envelope that's given to us by NHS England.
Okay, I think your answer in itself has highlighted what we were just talking about. So we've only got 5 minutes left for this particular item. So I'm just going to go through, whilst I have all the councillors on the call, the recommendations for the next estate agenda item that we would like to take, to make sure that I've captured everything from today. So I think I've already made a couple of recommendations around what we would like to see. I think particularly around this sort of the finance implication and the whole envelope that goes with it, to understand and not only the £3.4 billion for the 10-year capital pipeline, but an understanding of you know, the implications around that, because I noticed under the next, it says schemes for the next 3 years significantly exceed draft funding. So I can see where you're going with this. You're saying that, you know, you've got a lot of ideas and what you want to achieve, but it's the funding around that. So I think to really sort of focus in a little bit more on the finances, and understanding how any capital receipts from the individual NHS trusts, particularly across the new ICS, how that will be part of this. Is it going to be part of the ICS envelope whereby that money is equally, you know, just taken up and then used in different areas based on this ICS estate strategy board? Or do hospitals still have ownership of their own estates? And if they sell off a part, say the Royal Free sold off a part of its estate, does that estate, you know, does that money, that capital money, come back into the Royal Free, and can they use some of that for revenue spend if they can identify it alongside a one-off project, which is what I've been given to understand. You can spend revenue if it's particularly for money. You can use capital money as revenue if it's for a one-off project. And I know that's incredibly simplifying it, and Nancy, you're probably quite horrified of that oversimplification of things, but you know, it's how that really sort of takes place. So I think we've made the recommendations about the understanding of more about the governance structure, about the NCL Estates Board, about the Local Estates Forum. I won't go over that again. And it's really about getting, especially on slide 3, which was page 20. Yes, I'm not even going to begin to ask any of those questions, but I think every single one of those bullet points that is made in all those areas, we definitely need a greater depth of understanding of what each of those streams entails, because obviously as a JHOSC we can't scrutinise at this. We need lots more background information. We can do all the reading ourselves at home, and then we can come to JHOSC and focus in on maybe 1 or 2 areas that we know we've got particular concern around or would like to scrutinise further, because obviously we just haven't got the time available to do that today. I'm just going to check with colleagues on the call, and there was obviously a request. Councillor Clark made it clear about the other questions from the JHOSC deputation, to make sure that those are captured and that we get an answer back if those answers weren't given today. I think that can be an immediate update though to the JHOSC. We don't have to wait for the work stream for this to go into the next agenda item on that. So I'm just going to check with the councillors on the call. Was there anything else about this estate strategy that you'd like to put a recommendation in now, so that everyone's very clear about what the ask is for the next agenda item on this?
Yeah, just the point about the looking at alternatives, you know, to just to make sure that is on the focus. Looking at alternative. I know that Anthony talked about alternative funding streams. He's looking at that all the time, but just to focus on alternatives to disposal, you know.
And I think for myself, I mean, the other side of the coin that we need to understand as a JHOSC is about the gap that you have mentioned, that you have these strategic plans and that you have identified a £40 million gap, and then what would happen if that isn't, you know, you don't get that funding, what potentially could not be delivered. And I think that's really helpful, because I think you know that, but we obviously don't know that. So it gives us that understanding of the pressures in the system that maybe isn't obvious in the paper such as we have in front of us today. So that gives us you know, very helpfully in understanding, and that the joint partnership you're mentioning with the local authority, if these schemes aren't delivered, what impact does that have for us as a local authority? Obviously, these schemes will be happening in our areas, so for us, it's really useful to have some insight. So some examples on, you know, projects that would be coming down the line, and where that funding is, and how that relationship with the local authority, you mentioned the SIL money, and other streams of money and income, that would be really helpful. Thank you. So I'm just checking if there's anything else.
Pippa, when we look at the alternatives, can we see what the alternatives on offer are? Because I think it's really important. There's one point of looking at them, but it would be really good for us to know what they are, so that we know exactly how this has moved forward.
Thanks, Councillor Weaver. That's a very good point. Councillor Tomlinson.
Oh, thank you very much. You mentioned that 50% of buildings were not fit for purpose. I think it might be helpful to indicate, you know, the sort of buildings. Is it just surgeries, or is it other facilities as well? Perhaps a brief outline of what that involves. Thank you.
Okay, thank you. So I know we're asking for a lot of information. I note that this isn't before May, so just to reassure you, this will be coming up in the work programme in the sort of future. And any recommendation, I think, we would suggest to any future panel looking at this that they block off at least a 2-session on this, because to try and do it in the 40 minutes, even with all the background information that I'm sure you will be providing, and it'll be very clear to councillors sitting on this, there may be councillors on the next panel that won't have done JHOSC, who will not have, you know, had this meeting, so won't be as sort of, you know, so it's just to make sure that they have the time available to really scrutinise this and do it justice, so that we can have confidence and transparency going back to our residents about what exactly this strategy actually entails. So Nicola, over to you.
Yeah, I just wanted to confirm and to be clear, it's 50% of primary care that is not fit for purpose based on the DH requirement. So it's not the whole portfolio, and I think it's an important distinction to make, and it's by number. Thanks.
Okay, well, that is, because that's very interesting for us to know as well. That's really very important for us. Okay, so Nicola and Anthony and Sarah, I hope that was helpful in that sort of request back, so that you would be very clear as to what the next ask from JHOSC is on the estate strategy. And I appreciate you all coming today. I know you're all very busy, but thank you for the sort of the oversight, but obviously it's opened up for loads more questions than we've been able to answer or look at today. So thank you very much, and we look forward to the next iteration of this. So whoever's on the committee after May, I'm sure they will be grappling with this with gusto. So thank you very much for coming today, and yes, thank you very much. Okay, so
Good.
I'm going
Thank you.
Thank you very much. I'm going to close down this agenda item. So we're now moving over to the minutes. So I know this is a very strange way, but we've obviously, from time constraints today of people, we've gone through it in a slightly different way. So I'm just going to check with members on the committee. So the minutes, which was pages 1 to 10, if you have any comments on the minutes from the meeting. Okay, I'm going to note then that there was a deputation that was in the supplementary agenda pack. So I just wanted to make it clear at this point. So having looked at the CCG response to the JHOSC deputation in the previous meeting on the 26th of November, I suggest that as a committee that today we note the update from the CCG to the previous deputation, and we can add any outstanding actions or recommendations to our ICS tracker which is within the committee's work programme that we currently have. So we put those in the appropriate place within our tracker for the work agenda items. So I'm just going to check with the committee that's okay. I'm not seeing anyone saying no. Excellent. Okay, so there are other items from the minutes, but I think what I'm going to do is, because they're part of the I think work agenda, our tracker for the updates, we'll take them as part of the tracker. So there's quite a few recommendations that we've asked for. I would like to note here that we have had follow-up, we have had the responses back, but I have now got several follow-up questions from those responses back, but as I said, we'll take that as part of the tracker update. Okay, so that's the minutes. So there's the work programme now, which is on pages 39 to 52. So if I could ask the committee to have a look at page 39. Okay, that's actually Appendix A, which is on page 43. So that's our JHOSC work programme. So we've got the next meeting coming up on the 18th of March. We've got the Mental Health and Community Services Review to receive an update on that. We've got the LUTS updates to decisions that are hopefully being taken in beginning of March. And then we've got the finance report, which is the ICS, looking at the finances within ICS. And I've got Sarah's hand going straight up. Sarah.
Thanks, Councillor Connor. It was really in relation to the LUTS paper, actually. So committee members will have received an update on the LUTS paper in the papers today. In terms of an update, I think it is difficult to understand what to bring back by way of an update, because the arrangements are not likely to change unless the clinical guidance changes around how LUTS services should be delivered. And what we've done at the moment is just changed our arrangements to comply with the clinical guidance that we've received. So it would just be helpful to have a bit of clarity on what members would expect.
So we were looking at, I think from the latest update, there was still a decision, I thought coming in March, around the actual clinic. Now, is that all okay? Can you just sort of clarify that point then? Thank you.
So as the paper sets out, what we did was we had a review of the LUTS service, and what we found was it didn't comply with the guidelines, and we the paper outlines this in depth, and I haven't been leading on the review, but my colleague Paul Sinden has. And they reviewed it at the time, and they had the Royal College in to support with that review. The review identified the management of children with this disorder should be managed under specialist tertiary centres, and that a general service should not be looking after children and young people with this condition. So as a result, all specialists, all children and young people's referrals are now managed by GOSH and other tertiary units, and all the Whittington only continues to provide the adult service, particularly following the retirement of the professor that used to actually run the service. So essentially that service now complies appropriately with clinical guidance, and so we would intend to leave those arrangements in place unless the clinical guidance changes with regard to the how this service should be delivered.
Okay, so we're basically saying that the Whittington is going to continue to support the LUTS clinic as it was previously set up. The children go to Great Ormond Street, as has been happening over the period of time, and there's no change to that. Okay, sorry, I was under the impression that there was going to be a review into the Whittington's involvement and how that was being.
Well, I followed. Well, if I'm honest, I did see that, and I wanted to say what would the review. What would be the outcome of the review? What are we trying to achieve from the review, given that the current service model complies with the clinical guidance that we've got around the management of these disorders? And what we've done quite quite rightly, is separate the care of children and young people from adults, which I think is entirely appropriate and in line with the clinical recommendations. So from a strategic commissioning perspective, I would be struggling to understand what we were reviewing. What was the purpose of the review?
So it was the last bit. So it says plans in Q3, Q4, 2021-22. NCL CCG will support the WIT with a LUT service review prior to establishment of the NCL integrated care system in April 2022. That's on page 3 of the report. So as long as I'm clear that actually nothing is actually going to be changing, because that made it sound as if there was going to be a change from one system to the new ICS system.
And I think the point I've made to internally and to colleagues who wrote that report was, I'm not clear what the purpose of the review would achieve, because we are now compliant with clinical recommendations. I think children are getting, and young people are getting the right care. I think adults are getting the right care, and there is still the provision of patient choice underpinning that service delivery model. So I'm satisfied from that perspective that the service we have in place should continue. But I don't know if helpful to provide assurance of that in any way, shape or form, Pepper.
I think, I mean, you know, a very quick email would be the assurance to the JHOSC, because if you're not changing anything, then absolutely there is no point allocating the 45-minute slot to that. So I'm going to then open this up to members. So we've got the Mental Health and Community Service Review, and we've got the Finance Review. Now, the ICS Finance Pack is going to be substantive. So there's obviously an enormous amount of information for us that will be given to us as a committee on that item. And you know, I was a bit nervous that we had three big items. I know the LUTS item hopefully wasn't be quite so substantive. So it's whether we look to take the time to do the finance item in greater depth. Now the LUTS update isn't available, or whether we do look to take anything else on the you know, on the work programme that we've got already. Obviously not the one from estates today, because that'll be now after May. So that's now a substantive item. So I've got Sarah's hand back up, but I'm also keen to hear from committee members if they've got anything they want to suggest at this point. Okay, Sarah, do you like to come straight back and in on that?
Well, just to say, and it was probably just a bit in terms of managing the agenda, I would expect that there will be an area of commonality between mental health and community services review, but there will be a point where there will be different options. So it'll almost be like having two separate items, and I wonder whether it might be better and less confusing to take it that way. So we do mental health and then we do community. Okay, so the solutions around each one are slightly separate.
Okay, so I'm taking the community services review. We follow. You're saying the principles of the reviews will be similar. However, what they're looking at and the outcomes from those reviews will obviously be different because they're in different areas.
So I would still bring both back at the same time. So I'm just suggesting you may essentially have 3 agenda items without the LUTS. Yeah.
Okay. Yeah. Okay. That does sound because I've understood there is quite a lot of work being done on this community service review. Having had a chat with Caroline from Royal Free earlier. So excellent. Okay. So I'm just checking with committee members. Are you happy that the item 1, which is the mental health and community service review, is in effect 2 agenda items because there are 2 specific reviews into different areas that both affect our communities, and then we take the finance as the 3rd item. Paul?
Yes, thank you. And looking at the that sounds good. But looking at the other items to be arranged, they all seem to be quite big items. I mean, according to your guidance, of course, perhaps screening and immunization might be a smaller item, I don't know. But the others all seem to be quite big items.
Substantive items, I agree. So just thinking about the difficult, I mean, just noting how it was today, and to try and even get, you know, because the point of us is to scrutinise it, and to have too many items on the agenda at the point where we don't then scrutinise effectively, I think worries me. So taking on Paul's point, I think I'm more confident if we take the mental health review, the community services review, and the finance as those 3 items for that agenda. Although, as Sarah said, that the community and mental health has come under one as to one area.
We can certainly separate it because the findings are slightly different, the money is different, the direction of travel will be different. So it might be helpful to just have 2 separate reports.
Yeah, okay, no, that does make sense actually. Okay, so we'll keep the 18th of March as is. So we're going to put on under to be arranged, we're putting on estates back in with all the other recommendations that we made today. So obviously that's going to go, we haven't set anything because obviously, you know, this is ours goes up to the March meeting, and then a future committee will then look at what they want to place in under. But so just to be clear that we're under to be arranged, we'll be putting the estates strategy with a finance update as part of that. The finances around the estates, not the finances of the ICS. So the finances we're talking about with Anthony today, that we mentioned at the JHOSC. So hopefully those recommendations are clear, but we can go over those at a later date offline, Sarah and Chloe, if we just need some further clarification on that. So are members happy that that's how we proceed? Okay, Paul, is that, yep, you're happy? Okay, excellent. Okay, so that's that part. For the action tracker on Appendix B, I do want to just take sort of members' note of. We've got the deputation on the primary care and winter pressures, so we've said how that's going to be addressed. I said that as part of the meeting. We also had the elective services recovery update that we had back. We also had the fertility review. That I actually went to one of the public engagements, so that was really interesting, and it was really interesting to hear further updates from that. I'm just checking we've got the fertility review. Right, so on the to be arranged, Sarah, I know that we discussed putting the fertility review as a final update, so that needs to go on the work plan for the future when that comes out, because actually there's some really interesting challenges and conversations back from members of the public on that, so that would be very interesting to see how that's finalised. Under winter pressures, there was 3 points there. We had the e-consult, so I'm not sure I've completely understood, and I think I'd like further information around the e-consult, around it, about that question of whether this was the appropriate platform. I didn't feel that was addressed in the CCG update that we had back to the committee. So I think I'm just going to hold that open because I think we'd just like some further information on that. So that's winter pressures. That's the first one. The update on the proposed action for the London ambulance service waiting time. So a further update can be provided, timeline to be agreed. So again, that needs to go up onto the to be arranged. That needs to go under there because that will be an update to the committee. Now that could be a written update to the committee. That doesn't have to be an agenda meeting. So I just like that noted in the bit next to it to say that we would like that information back on the waiting times, because they were putting in new ways of addressing this, and we just wanted that challenge back from JHOSC was, let's see how that works and if that can actually do what they were hoping. the winter pressures on workforce. So the workforce bit is actually, we've got the workforce update. Now this workforce update is already pretty large, and we've also asked the Royal Free and the North Mid to also comment on that update and be part of that update. I think it was really helpful to understand a little bit today around the pressures on the workforce and what they're potentially going to be able to do as a new partnership to try and keep that workforce in place, understanding, of course, the pressures in the system, not only around the money, but also trying to retain staff and the pressures that are currently on staff who are feeling quite burnt out at the moment, and how we can all, you know, look for that challenge around how to sort of ensure that more staffing is there to support their colleagues in a time when we know that it's actually difficult to get staff in the front door in the first place. So I think there's that awful, almost catch-22 scenario, which I think obviously everyone's struggling with. So it'd be really interesting on the workforce update to put in the North Mid and the Royal Free particularly into that, so that we've got you know, someone to go back to and say, look, so how is this going to be achieved? Sarah?
I think it'd be really helpful to have a conversation about workforce, more that report and what you are wanting in it, because there are a couple of lenses that we can come at it from. And so, yeah, it would just be helpful to clarify that with you in sufficient time so that we can commission the report.
Yes, obviously this isn't going to be in this up till May, so I'm completely happy to do this with you at our next meeting prior to March and give you some clarity on that. I think it'd be really helpful. But yeah, just to note, there's no date for the workforce update yet in the diary for those obvious reasons. So everything else on the tracker, we've had the update on digital inclusions. So we've got digital inclusions and health inequalities. We had the members requested once a project had been given some time to mature in around a year, and it said October 2022 that an update report be brought back to the committee. So that's on the 1st of October 21 on the tracker. And just to note that that's actually not in the to be arranged section. So obviously that's been requested, but it hasn't been transferred up into the work plan. So just to note that that needs to be moved up into the work plan. So just checking if there's anything else that I noticed. It's really sort of just a housekeeping part at the moment, just to make sure that we haven't missed anything. We've got the mental health update, that's happening. We've got the update on the integrated care systems. Okay, I can't see anything else that hasn't been brought back up. So I'm just checking with members to ensure that there's nothing that I've missed on that. Okay, right. I think that's pretty much covered it, obviously. So what I'm going to suggest following the meeting today is that Sarah, you, myself, Chloe, and officers meet within the next 2 weeks, really, to make sure that we've got a real clarity around the agenda items for the 18th of March, so that everyone's very sure of what's been asked within the papers. I hope that's okay with both of you, and I know it's really difficult to ask for tight timescales, but I think it's better to get it in earlier rather than later, and then that'd be great. Okay, so that's it. So that's the end of the meeting as far as I am concerned. The date of future meetings is the 18th of March. This may be virtual or it may be in person. I'm really sorry, we can't give you any further clarity at the moment. It will be dependent on COVID-19, and it also will be dependent on ensuring we have the suitable venue, because if we can't do hybrid, so it'll either have to be one or the other, so we'll have to be absolutely certain, but officers will now start to have those conversations and to ensure that we have got availability in the areas that we need to go to, possibly Enfield, as we mentioned today. and we'll come back to the committee as soon as we know. So thank you everyone for the time today, and I'm just going to ask Fiona and Dominic to stay on the call afterwards, just to make sure that I've cleared everything. And then, but as far as the JHOSC is, I'm finishing the meeting. So thank you very much.